Good morning, dear friends. I am Dr. Sai Kumar. I am President of the Cochin Ophthalmic Club. And a very warm welcome to this CME on low vision in connection with the World Braille Day, which is actually tomorrow, which is the 4th of January. And the Cochin Ophthalmic Club is glad to be associated with our parent organization, the Kerala Society of Ophthalmic Surgeons, which is also observing Braille Day tomorrow. We are fortunate to have an array of good speakers. We are also fortunate to have our President, Dr. Babu Krishna Kumar, to officially inaugurate this meeting. Dr. T. Alexander, a very senior ophthalmologist and a former professor of CMC Vellore, has kindly consented to give the keynote address. He's a person who's very passionate about low vision, visual rehabilitation, which most of the general ophthalmologists in this crowd, including me, are not very. We don't probably focus much. We focus more on treatment rather than on rehabilitation. So this is, I think, one area where, as ophthalmologists, in our commitment to the society, we have to do more. And we look forward to hearing from Alexander sir regarding his views on this. So, this few words of introduction. I request our KSOI's president, Dr. Babu Krishna Kumar, to officially inaugurate this World Braille Day CME on low vision. And then Dr. Gopal Pillai, secretary, and who is the mastermind and brain behind all the CME programs, he will take over and he will guide us through the proceedings of the day. Babu sir, requesting you to kindly inaugurate this program.
Respected dignitaries, Dr. Alexander sir, Dr. Srini Adaklon, Mr. Niranjan Pehere, Dr. Geeta, and Mr. Deepak. Thank you, Dr. Sai Kumar and Dr. Gopal, for inviting me to this noble meeting on World Braille Day. COC has been observing this day continuously, a wonderful gesture. World Braille Day falls on birthday of Louis Braille, who invented 6-cell dot Braille communication system. This International Day observes awareness of the importance of Braille as a means of communication in the full realization of human rights for the blind and visually impaired people. Braille is not a language, but a code. Everyone deserves the same accommodations and service, regardless of ability. We do our part to make our workplaces more accessible for everyone. Let us dedicate for increased Braille literacy. KSO is doing its part for last 3 years by establishing vision enhancement centers in 3 places of Kerala. Dr. Srini Adaklon, the man behind this movement, will elaborate on this and future plans in his presentation. Let noble thoughts come from everywhere. Have a worthy Braille Day. With these words, I am inaugurating World Braille Day and COC Super Sunday's low vision course.
Thank you, sir. Gopal, you can take over. And
thank you very much, sir. It's indeed a pleasure to have such august speakers like Niranjan and Deepak and Dr. Geeta in an academic program in which it will be studied with Alexander sir's oration on the Braille Day. So last year, if you remember, we all had a very, very nice time learning Braille in the Cochin Ophthalmic Club. 3 kids who were actually blind came and taught us Braille. And we were there, our eyes were closed, and we were learning alphabet by alphabet and trying to pronounce small syllables based on our touch sensation. It was an amazing experience for all of us. But unfortunately, this year we have to move into this online virtual platform. And that is how, as Dr. Sai said before, we are, as ophthalmologists, we have an overwhelmingly high number of people whom vision can be recovered. And our sole efforts and our significant time will be spent for those people. So those people who come to us with already who are actually permanently and irreversibly blind, many a time, even though our mind says to stay with them and speak with them and at least give them the empathy and try to guide them, a lot of times we end up telling them slowly and sugar-coated that, nothing can be done from our side. And probably we will send them to a counselor and then we lose track of them. And as Dr. Sai said, we have a huge responsibility to this irreversibly blind people also. And this is part of that program where we as ophthalmologists should know how and what to manage in these low vision patients. What can they get? And when should we do that, etc. So before we start the academic program, we have kept two speaks. One would be Dr. Alexander Sir telling us about low vision, Braille, his contributions, and also what is our thought process in moving this program forward, in which he has a lot of ideas. And second, we will be putting the KSOS progress card on the low vision enhancement programs that KSOS has been conducting over 3 years. 3 years back, when Dr. Srini was a secretary, that program was launched, and he would be telling us about the progress card of KSOS. First, over to you, Alexander.
Thank you. Thanks a lot, Dr. Sai, Dr. Gopal, President Krishna Kumar, and other dignitaries. It's indeed a great privilege to talk about blind rehabilitation on the Braille Day. Greetings to all of you who are listening on this wonderful, significant occasion. The Braille Day actually got a recognition much later on in history, because the UN passed the Braille Day to be celebrated only in the year 2017, while the White Cane Day was celebrated in 1964. 2019 was the first year Braille was celebrated, and this is the second year the Braille Day is being celebrated. The next year, 2021, the World Blind Union will also join us and have a bigger celebration of the Braille Day. Now, Braille invention is the most significant invention in the history of the blind. And Louis Braille, who invented it, is included in the 100 inventors of the world so far. A few words about Louis Braille. He was a French citizen, born in the suburbs of France in 1809. And unfortunately, due to an accident in his father's leather shop, probably got a perforating injury which got infected, and he lost both his eyes. He joined the blind school in 1815 in Paris, and there he came across another system which I have to mention is Charles Barbier. You know, those days when Napoleon Bonaparte was ruling France, the battles were going on, and during the night, the messages were passed across to the different battalions, but unfortunately the battalion has to read the messages in light under the shade of a lamp, and this, the enemy picked it up and attacked them, and many were killed. To avoid this, he introduced what is called as a night writing system, where black dots were used to convey the message in a particular way. Based on the principle of this, Louis Braille invented the Braille system in 1815. Now, why are we celebrating the Braille Day? Because we know that we have a very significant blind population in the world. About 1.3 billion are affected by the visual problems. So the Braille Day is celebrated, actually that's very right, to increase the awareness of the challenges of the blind. Second, to increase awareness of the rights of the blind. The blinds are one of us. They have the same right as anyone else. In 2016, the government of India has also passed a law for the equality of rights for the blind. So they're one among us and they deserve the same treatment. The only thing is they have a problem and we have to deal with their problems. We have to encourage the government agencies, the NGOs, the teachers, and other charity organizations to realize the problem faced by the blind and make this country more blind friendly than what is happening when compared to the West. Not only the organizations, but the individuals also can take part by philanthropic about it, and they can contribute towards various activities of the blind. Braille is a code, it is not a language. They use bumps and indentations, and by tactile sensation of the blind, these bumps and indentations on a rectangle with 6 dots, different alphabets, different numericals are represented. It has now become so advanced that we have Braille in almost all languages, and we have Braille for music, we have Braille for computer sciences, and we have Braille in mathematics. So Braille has gone a long way in helps the visually impaired to write and read. Previously, they used to listen to all these books, etc., by hearing others read. But the feeling of doing it yourself, writing and reading, is a different feel. It opens an entirely different world to the blind. So when they start reading, what happens? They read all the books that is available in Braille. Of course, there is a shortage of few books in Braille. In many of the book exhibitions, the Braille books are not shown at all, and more books are coming. Bible has become, and many religious books have now been in the Braille format. So there is equality in literacy now, and that makes the blind independent. They can study better, they can score better, and they can get jobs better than before. So the Braille has empowered them in many ways. It has opened a big door for the blind. Now, if you take our role, I mean, most of the things my previous speakers have mentioned, that our role is mainly, as ophthalmology, is mainly on a preventive and a curative aspects. We know that cataract, glaucoma, diabetic retinopathy, ARMD, and trauma are the major cause of blindness, and most of our efforts are spent on the curative aspect of it. But we must also realize that 80% of our blindness is curable, while 20% is not curable. And that constitutes 1.3 billion people in this world. The problem these blinds are remaining without help is another big worry that we all have. So what can we do for this visually challenged people? I'm very happy that COC has come up with the visual, KSOS has come out with a novel idea, visual enhancing centers. Already 3 centers are set up, and my colleague coming later on will give details of the activities and the progress that is made by the visual enhancing center. There's a huge population requiring help from us in terms of low visual aids and the modern technological innovations. The smartphone and its applications, well described by our Dr. John in KGO, gives us an insight into what it can grow into. A big technological, many old people like us, we may not know much about it. So we need teachers to teach us how the applications of these smartphones and their applications are. It's not only for us, but it's definitely needed for the blind also. The second one is the congratulations to COC for conducting that workshop. Workshop was done by the blind children. They taught us how to read Braille. They know how a blind looks at life through Braille. And they also showed us that technology they can do better than us or equal to us. They were brilliant 2 children, kept us spellbound for almost 1 hour. COC in a small way has started a blind endowment fund for giving education to the blind, like scholarships, but we are far from it. We are a very fortunate group of people. We can do a lot more. Now, what can the society do for these blinds? If you look at the blinds in Western country versus the blinds or visually challenged in India, we all do the same thing. We go to supermarkets, we go railway station, airports, bus stations, all we do. But we have a very unfriendly situation in India. The blinds, it's very difficult to move around. White cane is not enough. So when we have new buildings coming up, you must use the tactile paving system, especially in railway stations and bus stations and airports, where the blind can easily move around. These tactile systems are only in few places. In the modern buildings, only few. I think we should make it mandatory to have this tactile paving for in all these cases. And more modern equipment which are coming in are quite expensive. Even for us, it is expensive. So I think the government should subsidize all these smartphones and their applications so that the blind and the visually challenged who are not in a very good socio-economical status to get all these things. You know very well that a low socio-economical status is associated with increased incidence of blindness. If we improve their finances, I think overall the blindness will also come down. And also the blind population, we have to spend a lot of money, and once you improve them, the money to be spent on rehabilitation and relocating, etc., will become much less for the government also. So we have a long role to play, the government and us. Don't push it everything onto the government. We all individually have got a long role to play. There are a lot of big, I must mention a few of the very famous blind people who have done very well. Of course, plenty of them. Helen Keller is standing first. But a new one which I thought it was worth mentioning was a guy in US called Daniel Kish. I don't know if you have heard of it. I'm hearing for the first time that he got something called the human echolocation, the same technology used by the whales to locate objects. He makes a sound, and the sound goes and hits an object and comes back to him, and he will tell you there is a pole there, or a wall there, or a large object there, or a small object there. It's something which he gives training also in US. He's the only person whom I have seen in video, of course, who goes around in the busy streets of US on a bicycle, and is totally blind. That's one. The second one is a person who is very near to us, our Tiffany Brar. He has come and attended the Ophthalmic Club a couple of times and told about the problems of blind she was facing. And she was feeling that the blinds are getting discriminated. We have no reason to discriminate the blind. They are one of us. We have to give them a privilege. We have to know their rights. They deserve everything that we should give it to them. Now, I must say that the word that Tiffany always speaks about is we need empathy, not sympathy. Empathy is acceptance of your problem. Sympathy is pitying the problem. The blinds can do almost everything that we can also do, but they need us. They need our help. If we give it to them, they will do much better than what they are. We need a lot of kindness in us to treat all these things. Kindness is a language which, according to Mark Twain, that the deaf can hear and the blind can see. Helen Keller says that other than being blind, the biggest punishment or biggest problem is having vision, having sight with no vision. So we have to look at them, we have to be very compassionate to the blind, and we must have a compassionate in sorting the problems out. India right now is not a very friendly country for the blind in terms of mobility and other things. But if we recognize them, if we educate them, if we empower them and enable them, I think we can turn out to be a very friendly, blind-friendly country. Everything in disease or anything, we are in the capital of that, but we should be the best blind-friendly country and not just a blind capital. So with this, the major problems I have described of the blind and what activities we should do and in which way we can take care of the blind, I've touched it up a little bit, and I close with greeting you once again for a very happy Braille Day. Thank you.
Thank you very much, Alexander sir. Thank you very much for that insightful lecture morning. Alexander sir is our senior from RP Center, and for other people's sake, I am just introducing sir. So he was the kingpin in Kollam before he moved to Cochin and started his Alexander Eye Center. So he's a very emotionally charged person in terms of management of blind people and how we can help the blind people. Even the first Cochin Ophthalmic Club Endowment Fund was his brainchild. Thank you very much, Alexander, sir, for that kind.
Thank you. Thank you. Thanks a lot for the kind words.
Yeah. And now we would invite Dr. Srini Edaklon, my immediate senior, who has a Ragni in his day, and then went on. Now he was the secretary, and when Shashi sir was the president of the Kerala Society of Ophthalmic Surgeons, when KSOS decided to start the low vision enhancement initiative, wherein they tried to get in some people trained in low vision, and then came up with the whole proposal. So, Srini, you are here?
Yeah.
So, over to Srini to give us an overview of the program as well as the 3-year progress report of the program. May I share the screen, Srini?
Yeah, please.
I hope the screen is visible now.
Yeah. It is, Gopal. Yeah. Thank you, Dr. Sai and Gopal and COC for giving me the opportunity to make a presentation on the KSOS Vision Enhancement Program. This was, in fact, a dream project for our KSOS team. We realized, as Gopal, Sai, and Alexander said, that there was a very significant lack of facilities in Kerala for the care of patients with low vision. So we decided to start low vision centers in different parts of Kerala in partnership with our members. So what I did was I contacted a few centers which have very good low vision centers. So I contacted LV Prasad, Shankar Netralaya, and Arvind Eye Hospital. But it was Arvind Eye Hospital and LICO who showed the maximum interest in our project. Dr. R.D. Ravindra, in fact, was really excited to help KSOS to start our low vision centers. So we decided to partner with LICO and Arvind Eye Hospital. And then we decided that instead of starting in all districts, we'll start it in 3 zones, North, Central, and South Zone. South Zone, Dr. JP was kind enough to partner us. So Amardeep Eye Hospital, Kollam was a center in the south. Eye Vision, Thrissur, Dr. Anoop's center was our partner in the Central Kerala, and Dr. Laila's Contrast Charitable Trust Eye Hospital in North Kerala. So these were our 3 centers. Once we selected our centers, we selected optometrists from there and sent them to Arvind Madurai, LICO, where they were trained. And after all the training, we had a capacity building meeting in which my presidents, Dr. Shashi Kumar, Dr. Radha Ramanan, the then Vice President, Dr. Meena Chakravarti, Dr. P.A. Mohan, myself, and the representatives from these 3 hospitals participated. So we were having our discussions. Then I suggested maybe instead of calling it low vision centers, we should, because that low vision, this thing carries some sort of this thing, the patient might not be really willing to visit that. And also we said we'll call them vision enhancement centers. So it was agreed, and so we decided that these centers in these 3 hospitals will be called vision enhancement centers. So with the active involvement, next slide please, Gopal. With the active involvement of my presidents, Dr. Shashi Kumar, Dr. Radha Ramanan, these centers became a reality, and the centers were formally inaugurated by the lovely Sri Kaidapuram Damodaran Namboodirvi in Calicut on July 11th, 2019. So from then on, Dr. P.A. Mohan has been actively and efficiently monitoring the activities of the centers. So this is a report card from July 11th, 2019 to December 31st, 2019. So during this period, 797 patients were seen at these centers. Among these, among the adults, a significant number were retinal diseases, including CNVM and diabetic retinopathy. Those with macular dystrophy, retinitis pigmentosa, all were there. 15 with glaucoma. Among the children, those with CVI were the major chunk. So when we you can see the slide at the end, the total number is given. When we analyze the data, we can see that 68.6% of those who attended our centers benefited from our intervention. This is a significant number. So, these patients were not getting any help previously. So our KSOS centers really helped in these people finding their way out with their whatever limited visual acuity they have. As Gopal said, previously we were only interested in treating, and they say, okay, nothing can be done. And what they do is they go to the Ayurvedics, the quack Ayurvedics, who say, oh, everything can be done. And see, they just treat them and they lose all their money. And that's it. So there are a lot of things that we can do. So as a state association, we felt that it was our responsibility to do it. And this was in that year. So we are actually tabulating the data for the year 2020. But when we consider the KSOS years, which ends in November, there has been a significant drop in number of patients visiting these centers. In year 2020, obviously, because of the COVID lockdown, COVID pandemic and all. So when you compare these 2 years, average 116 patients per month attended these centers in year 2019. In 2020, it came down by 50% to 59 patients per month. So Gopal, next slide, please, Gopal. This is basically because of the COVID problem. With the patients coming back to our hospitals, I'm sure the numbers will go up. But this, whatever we have done, is not enough. See, these 3 centers are not actually running to their 100% ability. Next slide, please, Gopal. See, what we can realize is that see, majority of the patients in these hospitals, in these low vision centers, or vision enhancement centers, are the patients that are seen in that hospital. See, I was talking to Dr. Laila. She says, like, even if they're not really sure how many have been really directed to the low vision centers, because the patients come, they either go to the pediatric ophthalmology department or retina department, and from there they go to the low vision center. So we have to make our ophthalmologists and other centers aware that there is a low vision center, because there has been a break because of the COVID. So we have to push things into our members so that they because it's their center. It's a KSOS center. It's not the center of these 3 hospitals. So they have to give the benefit to the patients at large. So to increase awareness, we have to conduct CMEs. We had conducted CMEs in the beginning, but we have to conduct more CMEs in different districts to increase awareness regarding the management of patients with low vision and the low vision management facilities that we have in these centers. So that is how, see, it's not just that. So we have to increase the participation of the general public. For that, we have to involve the NGOs like Lions, Rotary and all. So and also we have to involve the senior citizen fora. See, all these have to be involved. See, Dr. Babu Krishnamar, our dear president, has announced this as the Low Vision Enhancement Center program as one of his key presidential projects. So he'll be leading us. So we are out of the COVID problem. So we have to increase our efforts to make these low vision vision enhancement centers more effective. So Dr. P.A. Mohan is there. He is taking care. He's monitoring. He's pushing all these centers forward. And our plan should be like, increase the awareness among our members, increase more referrals from the at least from the centers or the eye hospitals in that district. Then once the capacity reaches almost 100%, we have to start more centers in the other districts also. So this definitely is a one-of-a-kind project. No other association, leave alone ophthalmic association, is running a project. See, a statewide project like this. So we should be proud of our KSO's leaders. And we should support our vision enhancement centers. Our president and the team, Dr. Mahesh and all, will surely take care of taking it forward. Once again, thank Dr. Sai, Dr. Gopal, and COC for giving me the opportunity to present a report card on the KSO's activities for the care of patients with low vision. Thank you.
Thank you very much, Dr. Srini. We are fortunate to have such visionaries among our society. And we also are fortunate to have the president as well as the vice president of the Kerala Society of Ophthalmic Surgeons. Niranjan, 1 second, Niranjan. Yeah, so we are very fortunate to have our president as well as vice president of the Kerala Society of Ophthalmic Surgeons. And I would like them to respond 1 minute before we go into our academic program. Over to you, Babu, sir.
I have told in my presidential address that this program will be continued this year also. And I entrust Srini to continue with this program. Okay.
Thank you, sir.
Yeah, I think we not only should we continue this, I think we should take it forward. And we should also see whether these vision enhancement centers in the future can also double up as visual rehabilitation centers. So I think these are the future directions, because a base has been made. We have 3 hospitals in 3 zones in the state, which is doing good work. Of course, they can do more as far as the number of patients and the number of visual aid distribution is concerned. But we should also think of converting them into vision rehabilitation centers, providing opportunities. And we have to take advice from seniors like Alexander sir regarding how we can move forward in this direction. So in the coming few years, Babu sir's term, the following terms and all, we should put in more effort on this. That is my take on that.
Thank you very much, Sai sir. So next we will start our academic program. I want to introduce to you Dr. Niranjan Pehre, who was our own DMP student at Amrita years back. Now he's a pediatric ophthalmologist with special interest in early intervention and cerebral visual impairment. He went on to LV Prasad and did his fellowship in pediatric ophthalmology. And he set up a children's eye care center at Vijayawada. So he started a center for interdisciplinary care for children with CVI, where children got all the services under one roof. He also raised financial support for the project so that every child could avail services irrespective of their financial capability. So he's a case study by himself. So later, he had led a committee that set up the national program of taking care of children with cerebral visual impairment for government hospitals across the country. And we have Dr. Geeta speaking on our Palakkad Government Hospital. Last year, he had done a 3-month fellowship at the great Ormond Street Hospital for Children, London. And right now, he's moved to Liberia, West Africa, And he is leading the Liberia Eye Center, which is the only modern eye care facility in that entire country. And apart from treating children and adults with various eye problems, he also leads the residency training program that basically prepares the next generation people. So Niranjan is a very accomplished ophthalmologist. In a very short span of time, he's a very young person. He has a lot of energy, and he has consented to speak to us on low vision practice for ophthalmologists, what we should all know. Over to you, Niranjan. We are eagerly awaiting your lecture.
Hello, good morning, everyone. Thank you, Dr. Gopal, for that kind introduction. Thanks to KSOS for organizing this wonderful program on World Braille Day. And I must congratulate the team KSOS for the phenomenal initiative that we have taken of setting up these centers for sight enhancement. I'm not aware of any other organization which has been so serious about this issue of low vision, because often we find that we as eye care professionals ourselves are blind to the importance of this particular aspect of eye care. Whenever Dr. Gopal asks me to do something, I have no choice but to agree with him. And it is always a pleasure to connect with our colleagues from Kerala. So thanks to everyone for this opportunity. The topic that is given to me is low vision practice, what an ophthalmologist should know. And the learning objectives are first to understand what is low vision and its importance. And when it comes to ophthalmologist and low vision, what is it that we all must do, irrespective of which specialty we practice and where we practice? Then things that would be great if one does, and things that would be ideal if one does. So first of all, what is low vision? The most common cause of low vision is its definition itself. If we refer to different guidelines, the ones by WHO, by UNICEF, by governments in America, Europe, India, different governments have their own definitions. But by and large, what is agreed upon is that any best corrected visual acuity less than 20/40 would be defined as low vision. Now, if we trace where this definition has come from, years ago in 70s, an expert committee sat together to decide what should be the cutoff to report low vision and blindness. Because different countries were having different norms to call as blindness. And they were again classified as social blindness, economic blindness, depending on what is the priority for that country. And there was no universal accepted definition. That is why they came up with this number. And that is all that has gone into making that definition. And it has gone across the board, crossed the aim that it was meant for, and now it has become the standard for providing the low vision care. So that's the basic aspect that we need to remember, that this definition was just meant for reporting purpose and not for providing service. So this defining number is meant just for reporting purpose and not for providing services. So anybody who is not happy with the visual acuity that we measure is a potential candidate for low vision. Like a patient with optic neuritis, with all the treatment, has recovered a visual acuity at 20/20, but he would be extremely disabled because of the poor contrast sensitivity. Or a person who has undergone a multifocal IOL implantation, again would be suffering badly from a poor contrast, and they may not be happy with the vision that they have. Now, before going on to the low vision, first we need to understand how we see and what vision is meant for. Traditionally, we all are taught about vision as something that is, like the electrical signals being conducted from retina by optic nerve to the brain, and that's it. But what happens inside the brain when those electrical signals reach the brain is something that we don't really probe into detail. So at occipital lobe, we have a very primary processing of vision where we understand the clarity, field, color perception, and contrast. And after this primary processing, there are some association areas which do further processing of the images. One is the posterior parietal lobe, where we have a three-dimensional map of the visual world. We understand distances of objects from each other, from our body, where our body parts are, and all these calculations are used basically for guiding the visually guided movements. And then we have the temporal lobe, where the conscious recognition of various things happens. So posterior parietal lobes work subconsciously, and temporal lobes, they serve consciously. And all this is finally linked with the frontal lobe, which is thinking part of the brain, which makes decisions. All this machinery has to have a stable frame of reference, which is given by the vestibular and proprioceptive system. And all this has to work in conjunction with an intact cognition and motor system to make use of the vision for any actions. So this whole gamut of processing is required for effective use of vision. Now, all this vision is meant for what? If we look from the evolutionary perspective, the paradise of vision that we have, it is meant for what? Professor Leah Hovorinen, in her this phenomenal book of What and How Does the Child See, she has divided 4 domains of activity which are dependent on vision. One is communication and interaction. Second is activities of daily life, activities that involve sustained near vision task, and orientation and mobility. Now, these 4 aspects of vision, they impose a different demand on the vision. So the way we use vision for communication is not the same as the way we would use vision for activities of daily living or activities for orientation and mobility. The importance of knowing this is that a child or an adult, his one aspect may be good, but other aspect may not be good supported by vision. So we might often see a child who is moving around quite comfortably, but he will not be able to read or write. He may be able to recognize people, but he will not be able to do other things of activities of daily life. So quite often we tend to get biased by this what the child or adult is able to do, and may not recognize that they actually may be impaired in some other area of activity. Now the key question here is, I'm a doctor and why should I bother about these issues? The fact is that for a large number of our patients, we cannot offer them any treatment beyond a certain limit. And for us, treatment is either medication or surgery. Habilitation or rehabilitation is someone else's job. But how many clinics can really have rehab specialists today? And it is not just about ophthalmology, it is true with many other specialties. You take neurology, orthopedics, there are so many patients where the treatment takes patients to a certain point, and after that we cannot really do much. And that is actually the biggest problem. And this problem has come in because we have that clear dichotomy between what is curative medicine and what is rehabilitative medicine. And this problem will not go away unless we rename rehabilitation as rehabilitative medicine and incorporate as a part and parcel of our regular training. This is because there are so many simple doable things which do not require a proper rehabilitation therapist. We can master and suggest to our patients, and they have the enormous potential to revolutionize somebody's life if we are trained that way. I realized this fact when I trained for a little while in Italy, where the neurologists themselves were doing rehabilitation. And when I asked them, you don't have any rehabilitation specialists? And they said, for what? And where are they? Because that whole country doesn't have any rehabilitation specialists. It is the concerned doctors who do all those things, and they are trained that way. So among the list of must-do things, the first thing is to diagnose and refer, counsel them about the condition, prognosis, and what is the role of the family. Appropriate referral to rehabilitation centers and therapists for services that are not available in our center. Communication strategies for infants with profound visual impairment. This is something very crucial. And save patients and families from pseudotherapists. So if a patient is not happy with the visual acuity that we measure in the clinic, he's a potential candidate for low vision services, no matter what is the acuity. Because acuity is a very small part of the phenomenon of vision, as we have seen what all processing happens in our head to process what we see. And those are routinely not assessed in our clinic. And the two most common ones which are not assessed but they are very important in our day-to-day functioning are contrast sensitivity and motion perception. So the 100% contrast that we see on the vision chart is something very rarely that we come across in our day-to-day life. Most of the activities that we do are with low contrast objects. And motion perception, hardly any of our activities involve a completely still objects. Either we are moving or the objects are moving, and this aspect of motion perception is hardly ever assessed in regular clinics. So one is the diagnosis, then second is the counseling and mentoring. Never say that nothing can be done, because what doctor says has a profound influence on patients' minds. But when we give some advice, we have to understand that the patients also go through a grief reaction and the different phases of this grief reaction. It takes them some time to come in terms with the situation. So the advice that we give may not be accepted immediately. Give them some time to accept it. Sometimes using a device is treated as a taboo by the family. So if it is a child, I generally give them the device in the beginning just as a part of the toy box. Let the child himself explore it and discover it for himself that this is actually useful in some way. Now, pediatric low vision has a special place because adults have previous experience of good vision. So it is easier to train them to do something. But a child has an understanding of the world using other senses. So that frame of reference of describing the world with the help of vision, if we use the same frame of reference for the child, we are not doing justice to the child. Child often does not complain anything because he doesn't know what is a normal vision. He thinks that the way I see, everybody else sees, so they may not really express the issues that they have. But we have to understand the issues by looking at their behavior. And depending at what developmental stage they are, their challenges are going to be different. So pediatric low vision is something that requires special expertise. So these are the 4 areas in which we can help these adults or children. One is to maximize the use of residual vision by doing good refraction, by teaching them simple scanning techniques. By these, at least we are able, we enable them to use what they have without using any additional gadgets. Low vision aids, either optical or non-optical. Deepak is going to enlighten us about this area. Environmental modification, simple things that can be done, which do not require any therapist, adjusting the light, the contrast, the color combinations, organizing the space. There are so many simple things that do not require any specialist, but they can help the child or adult a lot. Sensory substitutions, there are several touch techniques, hearing techniques that we all can master and suggest to our patients, which can be of enormous help. Like this child had rod monochromatism and was not able to open his eyes even in a routine room light. Forget about the outdoor sunlight. And this child, once we put a red filter on, is so comfortable. This little girl that we operated in Liberia for ectopia lentis, after the lensectomy, she has a residual vision of 20/100 in both eyes. But she's not able to read comfortably. A simple handheld magnifier has revolutionized the way she studies, and now she aspires to become a nurse. This teacher, who has lost his vision following optic neuritis, again has a residual vision of 20/100 in both eyes, and with this simple handheld magnifier, he's able to go back to his job, and he fondly calls it at his second eye. So we did not have a low vision optometrist when we started our work in Monrovia. So with this simple training that I took from Deepak, who is with us today, we were able to give little services to these people, and that was so helpful for them. Now, coming to these 4 domains again, if there is one domain that is most important, especially for a child who is very young, is communication and interaction. That is so very important for their development in other areas. And there is a growing evidence about association between congenital blindness, children who are born with very poor vision, and autism. A significant percentage of those, as close as 50%, tend to develop autism as they grow. And I realized this fact after dealing with a child with congenital cataract whose surgery was delayed for some reasons because the parents thought that something else can be done other than surgeries. They were too scared of surgeries and they came some months later. And I could see a significant change in the way the child is behaving. So initially we used to call them as blindism, but now it is getting recognized more and more that it is a form of autism, which is caused because of this very poor vision from very early days of life. So for the children, we need to have a different communication strategies to avoid this issue. And one book that I found very useful was this Baby Talk by Dr. Sally Ward. Actually, she wrote this book for children with normal vision, but a lot of these lessons can be translated into simple suggestions for parents of children who see very less from a very early life. So if these communication strategies are implemented, the child is less likely to go for autism, which is kind of a lifelong disability with no therapy actually to be practical. So the simple communicative suggestions given from an ophthalmologist for the family of a child who is blind since birth can have a very significant impact in terms of development or not development of autism in future. The other thing that we must do as ophthalmologists is to help the family understand how does the patient see. This is especially true for a young child because the child cannot express how he sees. If we just tell them that the child's vision is something like 20 by 100, or child cannot see things on the right side, or child's contrast sensitivity is impaired, it doesn't make any sense to them. We need to explain things in a way that they would understand, and simulators are very useful in this job. So we made a few simulations of different visual acuities and different difficulties with vision. So what we did was we took a video camera, focused it on the vision chart, and we just focused the line. Say if you want to make simulation of a visual acuity 20 by 125, so at 3 meters or 6 meters, whichever chart it is, at that distance, you focus the camera on that line. Others line should go blurred. And with those settings at that distance, you try to photograph various things that gives some idea about how would different scenarios look to a child with this kind of visual acuity. So if the environment is well lit and there is high contrast, this is how the child would see. But if the contrast is low and illumination is less, this is how the child is going to see. And if you take him outdoor where the light is bright and the details are very small, this is how the child is going to see. So we have pictures of different acuities made in-house for different surroundings, and that is how we educate parents that this is how the child sees, and that gives them a better perspective of how the child can be helped. If you want ready-made simulations, these are two excellent sites that give simulations of visual acuities of different level in different scenarios. When we say the child has left homonymous hemianopia, the visual field analysis usually gives us printout like this, where one half is cut. But actually, if you go into child's mind and see, this is how the child sees. This is very important to be communicated to the family and to the teachers. If you want this child to learn effectively, make sure that the teacher is in the seeing part of the child's visual field, and so is the blackboard. So never make this child sit on this side, but he should be seated over here. Similarly, when the teacher is writing something on the board, make sure that it falls in the seeing part of the visual field of the child. This is how the concentric constriction of the visual field would look like, and this child would have significant issues with his orientation and mobility in the school. He may fall down, it may be difficult for him to walk the stairs down. Walking up the stairs may be easier, but walking down is going to be more difficult. Impaired contrast sensitivity would give this denatured kind of a picture like this. Color desaturation, simultaneous agnosia. This is one of the issues that the children with posterior parietal lobe injuries face, especially if it is bilateral one. So if such a child is sitting in a classroom with so many things to see, his posterior parietal lobes are not able to analyze this crowded scenario well. So the child gets attracted by one thing that he likes, and once he focuses on that, rest everything else goes blurred. So that is how this patchy visual attention disables the child in crowded scenarios. So this is a small animation that we made to have an insight about how would a child with posterior parietal lobe injury would see. So when he is trying to locate his parents in a busy waiting hall, this is how they would scan the room. Now this looks very similar to like a tunnel vision, but the difference between tunnel vision and simultaneous agnosia is that they can see other things as well, but they do not get registered in their conscious mind. Their whole attention can be given only to one face at a time, and that is what disables them. And they also usually have a lower field effect, so when they try to look at the face and walk around, they get stumbled. So these are the difficulties that a child with poor acuity, simultaneous agnosia, and lower field loss would have. It is very important to educate the family. I think that is the whole crux of the issue. Once you educate them about what exactly is the issue, they are more likely to devise strategies on their own, because we do not visit the actual site where the child is raised or the child is taught. It is the parents and the teachers who know it well. And if we educate about the precise difficulty, they themselves can come up with a lot of strategies that would be helpful for the child. To understand what is simultaneous agnosia, I make parents play the simple games. Like in this crowded picture, try to count kiwis with red cap. You find it hard with good vision. This is how the child with posterior parietal lobe injuries face when they go in real world. This is what they have to face each and every time. We are facing it just for solving the puzzle, but for them, each situation in life is like solving a puzzle. What is dyskinetopsia? This is again not very well understood. So what happens over here is the child sees the scenario as snapshots and not as a continuous movie. Because it is a temporal lobe which connects all scenes, all the still pictures into a continuous frame, which is not possible when the temporal lobes are injured and they see the world like this in patches. That is why a child who is sitting over here would be really startled to see a teacher really next to him, because he has not seen the way the teacher has approached him. So such children have significant difficulties while playing interactive games where there is a lot of movement around, or any activity that involves movement. So such a child may have a 20/20 vision, and parents bring the child saying that, oh, this child just doesn't play with others. We throw a ball at him, he just doesn't look at it. There is something wrong with him, but we say that the vision is 20/20. So where is the problem? So these are some of the symptoms that we as eye care professionals need to be aware ourselves. Otherwise, we are unlikely to detect them in a child. So to understand what is optic ataxia, this again happens because of posterior parietal lobe injuries and the precise distances. It is basically the calculation of the visual surrounding that is not precise in the mind of the child or the adult. So they are not able to accurately approach and grasp something. And this is often labeled as a sign of stupidity or clumsiness, which is actually not the issue. So to understand this better, I often tell parents that you look at something through your mobile phone and try to do things looking into the phone and not your hand directly. So your frame of reference in the mind is quite different, and you find yourself a little clumsy while doing that. or you look into the mirror and try to do something, or try to do something looking into the mirror using your left hand, try to solve some puzzles looking into the mirror. So these activities give them some insight about what the child is actually going through, and that helps them develop that compassion and come up with strategies. Face recognition, we feel it is something so easy, but if you look at the mechanism in the brain which actually does the face recognition, it's a very, very complex task. And that is why in temporal lobe, there is a separate area which is dedicated for face recognition called as FFA, because it is a very complex task. And if that area is damaged, these children see the world as a faceless world, and they need to use other clues to identify a person. It could be a hairstyle, it could be voice, it could be the clothes, it could be the fragrance. So they have to take help of other clues. And we actually have some kind of insight of this issue of face recognition because of the masks that we use these days. If somebody using a cap, a face shield, and a mask, we have to go by either their eyes or some other clues of facial recognition, and that is what the children with face blindness go through. Difficulty in finding routes. Parents often bring the child saying that how many ever times you drop him at the gate of the school, he's just not able to reach his classroom. Or if the bus person drops the child at some place in the colony, he's not able to find the home. This is called topographic agnosia. Visual acuity will be good, but there is a problem at the temporal lobes which stores the map in the mind. To understand this, we often tell parents we have this puzzle where the bee has to find the rose, and this is how the child struggles every time if he has to find something. So you have to rehabilitate him in a different way. So the idea of giving these examples was that acuity is a very small part of vision. There is a lot more that happens in the brain which enables us see well and act on what we see. So we need to first educate ourselves about those difficulties and not check out a child from the clinic if the vision is 20/20. Now, this is like must do to recognize and refer. It would be good to do something called as functional vision evaluation. This is much more than just assessing the acuity on the chart, but it is to understand how does the child or adult actually uses vision for activities of daily living. It requires a separate dedicated time and a different setup. I believe that a doctor is the right person to do it because we have that complete understanding of vision. What all happens with the disease that we are talking about, how it is going to affect the acuity, contrast, color, and various other manifestations. If there is an involvement of brain also, what all areas are knocked off, so what all manifestations would be there. So we have that complete understanding. So with that, we are the right people to do this functional vision evaluation. So it cannot be done in a busy clinic, so we need to dedicate a separate time for it. How can you do that? Just the way you schedule a surgery. You cannot do surgery when the patient is in the clinic that day. You put it on another day. Similarly, we can dedicate a day and some time for this functional vision evaluation. It would be ideal to build a low vision service in your own clinic. I believe that it has to be an integral part of any eye clinic. You cannot think of an eye clinic where a cataract surgery cannot be done. Similarly, we cannot have an eye clinic where low vision services cannot be provided. Who can do it? A doctor is busy, especially in a developing country. There is a lot of morbidity that we have to manage. So giving time for low vision may not be practical, but then we can train somebody to do that job. Have some training yourself because you may be posted somewhere where you don't have anybody. Like when I was put in Africa, nobody knew what low vision is, but I had trained with Deepak for some time and I could use those basic concepts to train my people, and now they are able to do it. There is a significant challenge in getting devices. So Deepak will elaborate on that aspect as to how we can get those devices. Doing interventions, training people about devices is not an easy job. We often think that you just throw around this some magnifiers and that's it about low vision. No. To get a person to train, use, solve the problems, and above all, keep them motivated to use is a big task. It's a different science in itself. And Deepak himself has done a PhD in low vision, and it is something that requires a lot of training. If available, any training programs or self-training is required to well in this area. So it is not often about just the time, but the priorities. And one cannot do everything, so you have to build a team of people who would help you with that. Financially, it may not be very lucrative. I don't really believe in that, because you can price it. If people see value in what you do, they will pay for it. And for those who cannot afford it, there is a big potential for philanthropy because of the emotional appeal that this subject has. Follow is often an issue in our scenario, and that's fair enough, because not all parents have same level of motivation. It is always easily said than done. Families may have their own issues to do what you are trying them to see and trying them to do. And so we shouldn't make them feel guilty if they are not compliant, but be friendly and motivative. A day will come when they will follow you. So in summary, as an ophthalmologist, we must first diagnose low vision without putting any bar of number to it. Educating the family and the patient, how does he really see? And that may open up several avenues for ideas that the family can help the child or the adult. Counsel about what is possible. Never say this is nothing can be done now. There is a lot that can be done. It is our ignorance. There is a lot can be done. Appropriate referral. If we do not have the service, find somebody who can do it, and save the patients from pseudotherapies, like a lot of things that people get admitted for months and waste their time and money going for those. It will be good if one can do functional vision evaluation himself. Ideal to build a system which will provide all the services under one roof. How far you want to go, it is up to you. But the subject is so important that resource and help will follow. So thank you. Dr. Gopal, I'm done.
Thank you very much, Niranjan. Thank you. That is a very informative talk, to say the least about it. So what we generally will do, all of us will definitely take visual acuity and probably treat the patient. And we, even if the patient has complex neurological issues, we don't generally end up taking a lot of these functional visual functions. It's not just a visual acuity, but whether he can recognize what is his effective field, binocular fields. So what is the contrast in light? What is his contrast sensitivity in when he is in the dark? So a lot of these things you said, which is an eye opener for me at least. So if there are any questions, we can have those. You can stop sharing the screen, Niranjan. Yeah. If there are any questions, we can take those questions here and then move on.
Niranjan, this assessment of mobility.
Yeah.
I mean, all the people around you, do they have some special training for that, or it is just by for the children?
No, there is a separate module on orientation mobility testing.
Okay. Mm-hmm.
Yeah, as a part of the vision rehabilitation course.
Mm-hmm.
Yes.
So that helps you in finding out all these side vision problems and things you mentioned.
The child is actually taken in the corridors, then in the garden, in the whatever place available, and we actually observe how does the child find his way.
Okay. It's a big eye opener, and I've heard your talk before, but re-emphasized in my mind that all 6/6 vision children are not normal. That is, I think, a big re-emphasis that we have to do a lot more than what we are doing now. Thanks, Niranjan. Very nice talk.
Yeah. Any other questions? Niranjan, so when a patient, so from your talk, I would understand that even if the patient's vision is like 20 by 40, generally he will not be able to do the things that a 20 by 20 person will do.
Yes.
And patient's vision is 20 by 100, he will not definitely be able to do a lot of things which 20 by 40 person would do.
Yeah.
And so every patient with less, even patients with 6 by 6 or 20 by 20 vision is a potential candidate for the functional visual assessment.
Yes.
So that would be a very large community of patients who would be coming to our any hospital. It's almost like all the, the next patient who comes in will have a functional problem which we can solve.
Yes.
What is your thought process on that? How, when will you think that this child will require something like that? Only if the vision falls down, or even with good vision? Would you screen for such a condition?
Well, many a times the parents may not volunteer the difficulties that they have. So I generally ask them representative questions about those 4 aspects of functioning. Like a child with say a vision of 20/40 may not actually have any difficulty with orientation and mobility, may not have any difficulty with activities of daily living like brushing, taking bath and other things, but he may have significant difficulty with activities that involve sustained near vision like reading and writing. If the child has poor contrast sensitivity, we will have significant difficulties with recognizing the language of facial expressions, recognizing even the faces. So I would be more keen on asking questions about these 2 aspects. And if there is an issue, we suggest them adaptation strategies. So I think it is about very structured way of asking questions about the 4 domains of activity. That is when we pick up the disability.
Okay. Okay. Thank you, Niranjan. I think we have Mohan sir here, who also had spearheaded the KSOS low vision initiative. Mohan sir, do you have some words to share with us?
It's been a very nice presentation, and I think we learned a lot more about low vision rather than we are practicing now. The question is, any child which comes to your outpatient department with 6/6, do you test for contrast sensitivity and things like that as a routine, like?
No, sir. We in an ideal world, yes, we should be doing. But looking at the number of children and adults that we need to take care of, we cannot do this. So it should be a functionality-oriented assessment. Like depending on what the child's difficulties are, if they are not explained by the acuity, then we go to assess other parameters.
That means the contribution from the parents or the persons who is accompanying the child is more important rather than probably just the visual acuity and so on,
Yes.
right?
We need to have some evidence to probe further into detail, because that is going to take a lot of time and resources to do.
Would you require some sort of a psychology counselor or something like that for assessing or reassessing and things like that for these children?
Well, ideally should be a vision professional, because some background of vision training is required. But I believe that it's just not, for an ophthalmologist or optometrist, but anybody with common sense can do this job.
Okay.
Yeah.
I do. Thank you.
Thank you, sir. So maybe we can move to the next talk. I want to introduce to you Dr. Geeta, who is a graduate from the Calicut Medical College. And then she went to the Puttaparthi Satyasai Baba Institute of Higher Education for her DNB in ophthalmology. and came back and joined the government service. And as you know, government service is with a lot of patients with limited resources, but government is definitely improving the resources. So it's a journey where she started ROP screening. She had a lot of children with low vision, and she started looking at CVI and started managing these patients within her resources. So over to Geeta madam to hear her journey about CVI management in Government Hospital, Palakkad. Over to you, madam.
Am I audible?
Yes, madam.
Is the screen
Yes,
seen?
madam. It is audible, but I'm not. I'm seeing your screen, but you have to open the PowerPoint presentation. Yeah, please make it full screen.
Yeah. Good morning to all. At the outset, let me thank Cochin Ophthalmic Club and KSOS for including me in this program of Braille Day. I take this opportunity to express my sincere gratitude to the pioneers in CVA, Dr. Gordon Dutton and Dr. Leah Hiverman, for the inspiration and continuous guidance in our CVA activities. I also gratefully acknowledge the wholehearted support of our Palakkad ex-MP, Sri M.B. Rajesh and his team, Cochin and Palakkad Rotary Clubs, Health Service Department and National Health Mission, all in establishing a CVA clinic in our hospital. Now, coming to the topic, CVA, cerebral visual impairment literally means visual problems due to cerebral pathology. To understand CVA, we should have a thorough knowledge about visual pathways and tracks. And so let's start with the question, how does the brain see? Actually, Dr. Niranjan has made everything very clear, and so it's easy for me. We know that photoreceptors in the retina convert light energy into nerve impulses and they reach the occipital cortex, and early processing takes place in the occipital cortex for visual acuity, color vision, contrast sensitivity, and visual field. And processing of motion perception takes place in the middle temporal lobe. This data is transferred to temporal lobe and parietal lobe along two principal networks, that is ventral and dorsal networks respectively. Ventral is called the what is it pathway. He has explained it very nicely, which forms the basis of form and texture and orientation and visual memory. This temporal lobe is like a visual library, whereas the parietal lobe is the visual map. And this dorsal network goes from the occipital lobe to the parietal and frontal lobes. That forms the where is it pathway. I'll just give you an example. This pen, if I see this pen, if I have seen this pen before, my temporal lobe will help me recognize this as a pen by matching the images which is stored in the temporal lobe. And if I have to take this pen, my parietal lobe will decide how much distance is this pen from me, how my fingers should orient, how much force to exert. All this is decided by the parietal lobe and dorsal tract. And whether it is appropriate to take the pen, that is decided by the frontal lobe. And once the frontal lobe decides, it gives impulses, it sends impulses to the motor cortex, and the fingers, my fingers will go and take the pen. So, also this vestibular system and the proprioceptive system, they also play a role in this. all these activities takes place so synchronously that unless it is affected by some pathology, we will not understand how complex it is. Why I'm explaining all this is in our CVA children, this is what is affected. Vision in newborn is entirely different from adult visual system in the first 6 weeks. It depends only on tectopulvinar pathway, which carries motion and low contrast, fast moving shadows, which are very important in communication and emotional bonding. Mirror neuron networks plays an important role in that. And briefly mentioning about the visual milestones. A delay in these milestones are the red flags for the early visual development. That is eye contact, social smile, hand regard, watching and copying hand movements, the straight eyes at the age of 6 months, shifting gaze at 7 months, and goal-directed hand-arm movements, recognize familiar faces and objects at 9 months. We usually give these charts for the RBSK nurses and Anganwadis, where they see these such children, infants below 1 year, and we can even teach ASHA workers all these developmental milestones to identify the early developmental problems in the community. Cerebral visual impairment is a bilateral visual impairment in the presence of normal ocular examination, subnormal visual performance with or without normal visual acuity, in the presence of damage to early processing in the occipital lobe or in the visual association areas. The latest definition by Saki is that it is a verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairment. Low vision is not a typical feature of CVA. Children can have low vision. CVA children can have low vision, but not all. And it is becoming a most common cause of childhood blindness in developed countries, and in India also it's increasing. Actually, there's a paper by Dr. Niranjan and Dr. Gordon Dutton that in children under 3 years of age with severe visual impairment, 33% had CVA and 11% had combined CVA and OVA. And how will you suspect CVA? Usually eye will be normal in CVA. The child can have a coexistent ocular problem also, but usually eye is normal. But the visual functioning, visual performance will not be correlated with the eye findings. And always there will be a variation in visual behavior. If you see today and maybe tomorrow, if you assess the child somewhere else, the visual behavior may vary depending on the child factors like fatigue or discomfort, or environmental factors like visual clutter, background noise, familiarity with the object. All these affect the visual behavior of the child. And of course, there may be some traumatic perinatal problems and neurological insults, diseases. They may coexist. They may be there. And latency will be prolonged, and visual attention span will be short. And usually, some other developmental problems like motor, sensory, cognitive can be associated. So if you see all this together, we can suspect whether it is a CVA. And coming to a classification, this is just for understanding. This is an oversimplified version. That is, we see the brain, the 3 parts, forebrain, midbrain and hindbrain. If all the 3 are affected, that is cognition, mobility and vision, all the 3 are affected, it's a type 1, like global developmental delay. If only the midbrain and hindbrain are affected, then only mobility and vision, maybe only these 3 will be affected. These 2 will be affected. An example is a cerebral palsy. But there are exceptions. Cerebral palsy can have cognitive problems also. But this is I'm just telling you, just for your understanding, this is an oversimplified view. And if only hindbrain is affected, it's only CVA without any other mobility problems. And we should always understand it's a spectrum of disease from low functioning CVA where there is severe visual impairment to high functioning CVA where the child can see but cannot process and use the vision. Such children, such a high functioning CVA children may end up in as learning disability, ADHD, mental retardation, like this. They will not present as CVA, but we have to look for them. And babies at risk are premature babies, hypoxic ischemic encephalopathy, neonatal hypoglycemia, neonatal seizures, hydrocephalus, congenital anomalies, any neurological illnesses and encephalitis infections. All these can, all such children can have CVA. So in the history, we have to be very careful. And the pathology is periventricular leukomalacia detected in MRI as softening of the white matter around ventricles. The clinical picture, as I told you, a variation in visual functioning is a dictum. And vision loss may be from mild to severe. And visual field defects can be lower field defect or can be hemianopias. And color may appear washed out. Sometimes color preference may be there, like yellow or red. And face or facial expressions may be difficult to recognize. There is difficulty in recognizing shapes, size, letters, numbers, line direction and length. Route recognition may be difficult. Very common symptom is poor performance in cluttered environment. And the child may use tactile cues. This is the lower visual field defect. This picture is from CVA Scotland. And see this, both these pictures have same visual acuity, but contrast sensitivity is affected in the right side picture. See how difficult it will be for the child to see the face, because our face is a low contrast figure. So so in CVA children, what we used to tell them is like always enhance the facial features with makeup, with bindis and nose rings like that. And this is simultanagnosia, limited capacity to pay attention to several details of the scene. See, in a CVA child may be seeing this red balloons only. And in a class, child may be seeing this. Actually, Dr. Niranjan has very clearly explained how the child searches for the parent. And this is optic ataxia, impaired visual guidance of movement through visual world. A low functioning CVA child may become aware only when surrounded by a sensory tent, with nothing else to see. Crowded places may become frightening. Fast moving things may not be seen or may appear to be on collision course when actually they are not. It's called looming. So child may start screaming when a car or bus passes. Fewer elements of visual scene visible due to field or attentional losses, disturbing search, reading or copying. See how difficult for the child in the class. Eye contact may be abnormal. Child seems to look at the hairline when there is a center scrotum. And child seems to look past, not at the object. A child usually has less than 1/3 of the 60 to 80 atypical visual processing function. All processing problems will not be there in a child. So every child with CVA has their own unique pattern of vision. Every single component is affected in different proportions and different degrees in every single child, like a kaleidoscope. Each time when you shake a kaleidoscope, you see a different picture. Our aim is to find and know the limits and staying within them, using alternatives, extend the limits. The assessment part, it should be a transdisciplinary one, involving the neonatologist, pediatric neurologist, pediatrician, ophthalmologist, optometrist, therapist, and even ENT surgeon or audiologist, because sometimes auditory impairment may be associated. And how to approach. And the first visit, we have to make sure that it is CVA. Then do a proper eye evaluation to look for any treatable ophthalmological problems associated, like sometimes refractive errors may be there, or cataract may be there, or strabismus. Then do a proper counseling. A word about counseling. Like these children, these parents will be hearing a lot of things, like eye is normal, brain is abnormal, brain is affected, like that. So what we in our clinic, what we do is make them understand how the child sees the world. we used to tell the parent that only if you know how your child sees, then only you will be able to help him by arranging proper environment to use the vision. We always encourage them to see through the eyes of the child. And one more thing we have to stress is we should tell them that you are the only person giving the training by infusing vision into daily life, daily activities, and we are here to help you. I think this makes the compliance better. And we always try to give a concept of neuroplasticity also. That is, repeated successful and meaningful experiences can encourage the brain to find other ways to make sense of the visual information received. So then parents will be more motivated. We have formed a WhatsApp group for the Drishti, that is our CVA clinic, which helps them to get motivated. And also we now in this period of social distancing, we have started teleconsultations to motivate the parents mainly, and make them not to stop the vision intervention therapies. So that is also useful. And coming to the eye evaluation, the main thing is the child should be well fed and should be very comfortable and happy. Then only we will get a good result. Sometimes the head control may not be there, then we can examine in supine position also. Room should be clutter free. Actually, our IPDs, OPDs are not a good place for, because we have a lot of gadgets, a lot of equipments there. So we have to find a separate room, well lit with curtains, because sometimes we have to dim the room, because some children may behave well in scotopic illumination, and a sensory tent also, because some profound CVA children will behave well in sensory tent. This is our CVA clinic. So whatever equipments we have to keep in the shelf. And we don't have a tent, but we have a cabin there. And visual acuity should be like, depending on the age. Pre-verbal children, we use LIA gratings. And then 3 to 5 age group, we use the LIA symbol book. Puppet faces are also very useful because they are more biological. Do a proper retinoscopy, because studies shows that 10 to 60% of CVA children have significant refractive errors. And the most successful and cost-effective intervention for a CVA child is spectacle correction. So should be done at the earliest. And dynamic retinoscopy should be done to look for accommodation lab. There are studies that around 50% of cerebral palsy children and 80% of Down children can have accommodation losses. And this our anterior clinical examination, anterior and posterior segment examination is a must. Sometimes it will be rewarding like this. We saw a 3-month-old baby without eye contact. They brought to the CVA clinic, and it was a bilateral retinoblastoma. We would have diagnosed it later, maybe after 6 months, maybe baby will present with a leukocoria. But because of early diagnosis, the fovea spared, and we could save the vision in left eye. So, and next is the proper history taking. In order to prevent omissions, we use a structured clinical inventory that is invented by Dr. Gordon Dutta. We have translated it to Malayalam, of course, with his permission. There are two types of inventories. One is for children with less than 6/60 vision, and one is more than 6/60, like elder children. Once the parents fill these answers, then we will have we will get a profile. What are the visual problems? Like the examples, we ask them whether there is any problem with climbing the stairs, or whether the child is able to get the toys from the toy box. All these typical questions, and then they will give the proper answers. Then go for a functional vision assessment. Unlike visual function assessment, this is done binocularly in a dynamic environment to find out how a person uses vision to perform tasks of daily life. And this is the protocol we follow. functional vision assessment. This facial communication distance is the communication distance when you go near the child with a silent smile and look at what distance the child take notice. And mirror test is to see whether child recognizes the face in the mirror. And then we do the ear gratings. See the child looking. It's a 6-month-old child. It's a normal child. But this always explain the parents the line thickness the child could appreciate compared to the fingers, because then only they will understand how the communication should be given to the child. And there are some special situations in CVA, like strabismus may be there, saccadic eye movements may be affected, nystagmus may be there, head control may not be. So in such situations, other clues should be taken, like change in facial expression or stilling of respiration. All this can be taken as a clue for vision. And this is hiding Heidi for contrast sensitivity. See this child, if the infant responds with a social smile, he must have seen the picture of the smiling face. So this is field analyzer, Ria Vand. With this, we see the field. Or in other children, we can use a puppet face from behind the cardboard. And if the child can stand up, we can use a leg raise test also. Then look for latency, span of visual attention, pursuits and saccades, evidence of blind sight. All this should be done. Then cognitive visual assessment. This is usually in high functioning CVI. Such children suspect this when child has normal or near normal visual acuity, yet has issues with using the vision. Such children may present as learning disability or ADHD. See, this is a child who presented as learning disability. 11-year-old girl, see how she's trying to keep it. She's not able to understand the shape. First of all, she's not able to recognize the shape, and she cannot keep it in the slot. So both the dorsal and ventral systems are affected. And this is linear rectangles, like the size. We have to keep it according to the size. And this is for visual spatial orientation, Marsden and Ball. And the CVA children, they sometimes it's very difficult for them to understand the expressions. So this is as a testing tool to see the expressions. All these cognitive visual problems, we can use these tools as a testing tool as well as a training tool. Both can be done. So if there is any problem, you can teach them. And you can use photos also for to teach expressions. And this is Leah mailbox. See this child, how she is taking tactile clues. See she's taking tactile clues for keeping it. And then eye-hand coordination. We can ask the child to stack rings and put things in the container. Visual closure, this is very important in reading. And coming to the visual intervention, it is not visual stimulation. Actually, visual stimulation is a passive thing, matching high contrast visual stimuli in the darkened room. But visual intervention is an active, dynamic, and interactive approach. Instructor chooses specific meaningful stimuli found by assessment, makes adjustments while looking at the reaction of the child. It should be carried out within the context of major developmental activities like communication, movement, play, and learning. Child needs support to recruit and use visual system because this does not come naturally. The two problems are helping the child to use available vision. First, you have to create a visual awareness, visual curiosity, and visual interest. And secondly, helping a child understand what is seen. Making sense of what this requires constant interpretation by the adult. And slowly we can build the visual discrimination and efficiency. Always we should prepare the child for a session by a bouncing or hug or something. And we can use some apps for a warm-up session. Then always communication, I told you, you have to enhance the facial contrast. And always stay within a child's visual sphere while talking and provide tactile inputs. Always use radio language and infuse vision into daily routine. That is the principle we are using. And we must have seen such children, lot of children, without any visual awareness. See, in a very low functioning CVA, we can use a multimodal stimulation, multisensory stimulation. We can use illuminated toy with auditory and tactile elements added to it. Then the children will have a visual curiosity and will try to look. And we can use light box, and always this sensory tent is also very useful to help to declutter the atmosphere. And this is the early language training by Dr. Gordon Dutton. It's called Kiss Me principle. Like spend time with the child in a tent and repeatedly say a single meaningful word after each singular meaningful consistent experience, slowly and loudly. That is, keep it slow, simple and meaningful. Because the principle is that if the posterior parietal brain can only process one element of input, because simultaneously, it can be auditory also. At the time, then it is essential to label that experience with a single word so that the child can learn. This learning of language will allow these children to use their limited vision and thus help in the whole development. So this should be done urgently because language is very, very important in such children. At least passive language, because child should be able to understand. Then there are different strategies in habilitation, like lack of vision on one side, sitting on one side of the classroom and rotate the plates. Like some children may they keep the food stuff uneaten in the plate. So always make it a practice to rotate the plate in hemianopias. Then lower visual field impairment. Use the floor space clear of clutter and white shoes for more visibility and adjustable reading stand. Then reduction in contrast sensitivity, you can use felt tip pens, and gaps between the lines very important. And stairs should have good contrast. And facial expressions is very difficult. So always put language to all emotions. And naming of the color, abstract thing, they may not be able to understand. So keep insert a key noun in the front, like sky blue or grass green. And root recognition, for them, for root recognition, you can compose some stories or songs like that. And sometimes the child may not be able to, high functioning CVA, they may not be able to write in a line. So you can use a typoscope, a simple thing, but it can change the life of the child in the school. Then always we should tell the teacher that don't insist on eye contact, because teachers always, even parents, they insist on eye contact. It's very difficult for the child to see and listen at the same time. So you can teach the child to look between sentences. So like that, adjustments can be done, and always teach the child that it's okay to be different, atypical in functions. We must not forget these 3 rights of children with CVI, that is right to learn, right to independence, and right to effective social interaction. CVI can be very disabling but trainable. With the right training at the right time, their skills can be enhanced. Thank you for patient listening.
Thank you very much, Madam, for that enlightening talk on cerebral venous, CVI. Are there any questions? So, Madam, you are doing fabulous work in Palakkad. Thank you. You've made Kerala ophthalmology proud. Thank you very much, Madam. And Niranjan, will you want to add something here? Or Dr. Deepak, would you want to add?
I learned so much from Dr. Niranjan because when I started this CVA work, I used to pester him with a lot of his doubts, and he was very patient in answering all this, clearing all those doubts.
Yeah, it's really nice to see the way Dr. Geeta has built this service in North Kerala, which is not easy to do in a government setup. And looking at the age at which Madam has made this transition from a clinical ophthalmology to a rehabilitative ophthalmology is really commendable. So thanks for what you're doing, Dr. Geeta.
Thank you, sir. Thank you. After so many years, we are seeing.
Now, if there aren't any questions, I would move to the much awaited talk today by Dr. Deepak Baga. Dr. Deepak Kumar Baga did his diploma in refraction and optometry from UP State, and then followed by a 2-year fellowship in optometry from LV Prasad Institute. He received his PhD from the School of Optometry, University of New South Wales, Sydney, Australia. And since 2007, he has been associated with LVPI Hyderabad as a consultant optometrist. His clinical area of interest is management of patients with low vision. His research interests lie in measuring the impact of low vision on individuals' participation and quality of life and various contextual factors that may affect participation. He has multiple publications. He has 14 papers in peer-reviewed journals. He received the Amjad Radeep Prize for the best poster presentation and multiple other awards. Over to you, Dr. Deepak. We want to hear pearls of wisdom on low vision examination as well as optical devices, which will actually transform our ophthalmic management practice.
Thank you so much, Dr. Gopal, for kind introduction, and the Kerala Ophthalmic Society and Cochin Ophthalmic Club for having this event and inviting me for this talk. It's my pleasure to share the learning that I had while my work and during my fellowship at LV Prasad Institute. So I was fortunate that herein I had the opportunity to learn and practice and research. So all those three things I could do, and I'm passionate about low vision and rehabilitation. So next 20 minutes or so, what we'll look at is the pearls of low vision examination. So herein what we will learn at the end of talk is what is the purpose of low vision rehabilitation, different elements of low vision examination, the procedures, methods that we apply for calculating magnification, because that is the basis for selection of assistive devices. So once we learn the calculation, then yes, that will help us to decide about the devices. I'm sure many of you know what is ICD, but I'm not sure if you have heard of ICF. ICF stands for International Classification of Functioning, Disability and Health. This is a classification given by World Health Organization to explain the functioning aspect. So if we look at the implication of functioning of a health condition, you can understand it at 3 different levels. You can assess it at the organ level, you can look at the individual level, or at the societal level. So when we look at the example given here, so say if we take macular dystrophy, if you're looking at the structural level, organ level, so we look at how it has impacted the person's acuity, contrast sensitivity, central visual field. When we plot on Amsler, we look at the color vision and other visual function, how the depth perception has been involved. So those are all at the organ level. How those clinical information relates to the individual functioning, when we look at that, is called activities. So how that impairment or decrease in the visual functioning of different visual functions has impacted the person's ability to perform a task is called activity limitation. So because of that decreased acuity or contrast, person may have difficulty in identifying team members during play, may have difficulty locating the ball. And how would that affect at the societal level the person's involvement in life situation, which we call as participation? In the earlier classification, which was named as ICIDH, which is called International Classification of Impairment, Disability, and Handicap, in that the term handicap was used to explain what we today call as participation restriction. And the ultimate goal of low vision rehabilitation is improving participation. So that is where this ICF and understanding it plays an important role. And anybody practicing rehabilitation, whether it's for the visual rehabilitation or physical rehabilitation or any other area of rehabilitation, they have to understand and that what are the various broad areas and categories under activities and participation. So what are the domains, what are the broad areas wherein person may be functioning? Because if say we talk about visual impairment, we need to understand what are the areas that can have implication because of decreased visual acuity or a particular condition. So that may affect person's learning, applying knowledge, mobility, general tasks in day-to-day activities, domestic life, self-care. So a number of things are there. So those broad areas have been classified into 9 domains in this ICF. And another important component which people say is the social component of this model, wherein they say that everything cannot be explained by the clinical measure. So when we in rehabilitation, when we look at the outcome, often we are rarely able to explain that person's participation with the clinical measures. So there is a poor correlation which is often reported. About 30% of the variance in person's participation can be explained by the high contrast visual acuity measured in the clinic. So what are the other factors apart from the vision that could explain? So those could be at the personal level, person's intrinsic motivation, their preferences, their self-esteem, and so those things may be, and level of enjoyment. If a person doesn't enjoy doing things, they may not go to play. But so those are the things at the personal levels, and there are other things which could be involved, because of which when we see there are 2 kids with say Stargardt's disease or heredomacular degeneration, both functioning completely differently. One is has discontinued education, whereas the other may be scoring very well or maybe top ranker. And the difference could be in their interest level. The difference could be in the support that they get from their parents, from their teachers, from the colleagues. So the physical social environment, which we call as contextual factors, also may be influencing their participation. So in the rehabilitation, we do the holistic assessment, not only the participation restriction, but also try to understand what are the personal and external factors that may be influencing the person's participation, because that helps us to plan the management in a better way. This is what American Academy of Ophthalmology 3 years back gave as the purposes of low vision rehabilitation. So in their document, they have listed these are the broad specific objectives. So first one is maximize access to printed material. We know that majority of the patients come with the expectation that I should be able to read. Reading is a major issue which they report. The second is ability to accomplish day-to-day activities, which again is listed in various domains which are listed in the ICF framework. Improving safety, not only during the mobility, but also working in kitchen, while working in the chemistry lab. So based on their occupation, based on their role, they may have various hazards which because of the vision has posed. And we have seen risk of fall in patients with glaucoma, patients having field loss, and there are reported that people having additional disability because those issues were not addressed in time. People were just focusing on taking care of the controlling IOP rather than looking at that, yes, how would this damage in the visual field affect the person's mobility, and will it pose person risk when they drive or when they go around to different places on their own. So should they be assessed for their mobility and trained in safe navigation? And if the person's those issues are not addressed in time, yes, person would start looking at that what time should I go, and if the social event is in the evening, should I participate or not? You see that most of the patients having RP, retinitis pigmentosa, because of their challenges, they may not travel on their own or may avoid social gathering and all those things where it's a crowded place and if they don't recognize. So because of those reasons. So that is again an issue which we want to address, that how do we improve the social participation of them? And if you have not addressed it, yes, that may have emotional, psychological issues, and how those can be addressed. And overall, if you look at, yes, ultimately it affects the quality of life, and that is the ultimate goal of overall rehabilitation, that okay, when you're improving the person's participation in all these areas, certainly you expect improvement in the quality of life. These are the 5 major components of low vision examination which you should look at. Very first one, I'm sure you all do it, reviewing the medical record. So we will look into it, what we do through that. And then, as I said, that we also need to understand with what expectations people come to the low vision clinic. So expectations are created by what words are given by the ophthalmologist when they refer. So if they have told person that you'll be given a magic glasses and you'll be able to perform whatever you're missing, then that is what it will be. So this was by Michael Crossland's work, wherein in his low vision clinic, he reported, we come across if the patient's expectations and our management plan doesn't match, they would have, they'll not be very satisfied because they expected something. In the review of medical records saves a lot of time. There's a myth that low vision examination takes a lot of time. It takes if people have not prepared themselves well. For us, it takes about 30 minutes, a maximum 45 minutes for the assessment, completion of assessment. For that, what is prerequisite is you go through the records so that you understand what the patient, because at different age group, people would have different life roles and different occupation. So say 7-year-old person's requirement will be, if he's in class 2, will be different than if somebody who's 17 or 27 or somebody 77. So 27 would be probably in the transition phase, finished with the education, looking for employment. 77 may be retired, may be working, depending on what their priorities are at that stage in their life. Presenting symptoms, how they are, and whether it's a stable condition. Like albinism, you see things are stable, whereas in RP or in AMD, things may be progressively worsening. So despite knowing the condition, person sees that there's no treatment and they may have challenges in accepting things. Something happened recent onset versus long standing for 3-4 years, it is there. People have already consulted 4, 5, 6 different places. They would have probably accepted the situation and would be looking for rehabilitation, versus somebody just had 2 months back or recent onset. They are still exploring the medical intervention, so they may probably require more of counseling. So we look at all these different components which may help us to plan our rehabilitation. And if the visual field, color vision, visual acuity, clinical information is well documented, that guides us that gives us the starting point to start working on it. If things are missing, we ask those things in a structured format. The second component of examination is observation. So like one of you panelists asked that, how do you assess the mobility? So when we escort the person from waiting lounge to our clinic, it's a new place for the person. How do they negotiate the path, whether they can find their own way, they can find their chair in the examination room, or they struggle, they take somebody's help. So there may be person having 20/20 acuity but advanced field loss, and they may be struggling to find their way. So postural abnormality, their navigation, all those things can be observed. We can also observe somebody is using very high powered glasses, tinted lenses, or any special aids for helping themselves. Say if they are already using wheelchair or hearing aid, there's a possibility that person has accepted for other disabilities, so compliance may be better. So in rehabilitation, we know that what main purpose is, but how do we assess it? So there are multiple visual function questionnaires available, standardized questionnaire for different age group. For for school age group, school going children, we have developed LV Prasad functional vision questionnaire, which has 23 questions to understand their functioning. And some of the example questions are here: copying the small letter from board, reading, and not only reading, because playing games and other things also may be important. So explore the complete area with that questionnaire. You see that which are the areas that you want to address, and in that detail you have to be very specific. If they say reading is problem, what print says they want to read? What books do they read? Do they read children's book? So if they have brought the sample books, we can look at the font size, because that will give us the target threshold print size that we want to place it while calculating the magnification. The other myth is people say that it's a trial and error method. No, low vision devices are not based on the trial and error. It's all scientific method. If people understand how do we get that in the history taking and in the visual function recording, you can calculate and you can save a lot of time in selection of devices. We discuss about the context. So we also want to understand in what context do they need to work? How is the lighting situation there? How is the contrast on the board? So if the difficulty with the classroom setting is there for child, so say having difficulty to copy from board, at what distance do they sit? So see an example here, where in the history it's recorded that yes, child sits about 6 meter distance. If he moves from here to 2 meter distance and sits in the first row, without any magnifier, he can get 3 times magnification because you have moved him 3 times closer from 6 meter. So this is called relative distance magnification, and it works for majority of the patients who have 6/30 or better acuity. And there was a paper from Shankar Netrale wherein they had reported that most of the kids 20/100 or better acuity can manage if the teachers write little bigger font size, which is about 3 centimeters in size. And if that recommendation letter is given, even if you don't have assistive devices, most of these kids can be helped. So understanding the environment is also important in the history taking. In the clinical examination, if you see most of the content, what you are seeing here, you are familiar with visual acuity, refraction, color vision, visual field. Contrast sensitivity is something which people do not do often, but this is something important. And glare testing again is not done routinely. In low vision, how do we do things differently? We don't use a standard test distance of 6 meters all the time or 3 meters. At times you have to bring the chart at 1 meter. As you see, my colleague is using a test chart at 1 meter to record acuity. So when you reduce the or you are not using standard test distance, you can probably able to quantify rather than recording as counting fingers. So if person has low vision and acuity is lower than 6/60 or 20/200, it helps to use a non-standard test distance. Encourage them to use eccentric viewing. When we say appropriate test chart means often people feel that you should have logmar chart. It's ideal, but even if you have a Snellen chart or if you're having comp log or anything else you are having in your clinic, you can still record things at shorter distance and rather than using counting fingers, because that is not a standard method and not reproducible. So we suggest to people to use it non-standard test distance, and you can see through this example how it helps. So in our comp log, that is arranged. If you're recording at say 3 meter distance, you can record from lowest level is 20/796. The best acuity that you can record is 20/10. That is the range. If you record at 1 meter, the range, you can see that how it has as low as 20/2388 you can record. If you record at half meter, this can further be further lowest level of acuity you can record. And the simple way of calculating these things is if we have gone 3 times closer, multiply the denominator with 3, you will get the acuity. So there's a chart which is calibrated for 3 meters, and person has recorded acuity at 1 meter, wherein patient read 20/317, the acuity can be calculated. So denominator multiply with 3 because you have gone 3 times closer, you get 20/951 is the acuity that can be recorded in the person's record. So that way you can calculate, and these numerical values will help you to calculate magnification for distance. A person's acuity cannot be recorded even at half meter with this chart that you have. You can use Berkeley rudimentary vision test. This is a chart developed by Ian Bailey, the person who developed logmark based all ETDRS charts. So he has designed this, and in this there are 3 cards, and with the single tumbling E card, which is designed on 25 centimeter by 25 centimeter card, you can record as low as 20/2000. And if person fails to read the largest optotype even at 25 centimeter, you can go to use the grating acuity with which you can, and here, and if you see the intervals at each level is about 0.2 logmar as compared to in logmar where we have 0.1 logmar. And if person fails to read the largest grating acuity, you can further record with the basic vision card pair where in person has to just identify which hemi field is white, and or if the complete card is black or white, if that person can discriminate that, you can record up to logmar 3.5. So this way the ultra low vision can also be quantified rather than recording CF or CF half meter, which is not a standard method. And in near acuity, we use again logmar based near vision chart. Usually we use a word reading chart developed by Ian Bailey. And for our patients, we have developed it in Telugu word reading chart in consultation with Ian Bailey. So that chart we use it. Here in the beauty is that the chart the largest opto type here is N80 font size. And we start, the top line itself is the largest. So person sees a couple of lines they can read before they reach their threshold. The other thing which is important here is when we record, the test distance should be guided based on the addition given. Often you see that people give +3 add as a standard for anybody, aphakic, pseudo-aphakic, irrespective of thinking of that where do they want to work. Think of a young kid. They may be keeping, because of the shorter arm length, they may be working at 25 centimeter or so, or 20 centimeter. So, but if you give 3 diopter add there, it will focus only at 33 centimeter optically. So how will they function at 20 centimeter? So things will be blur. For relative distance magnification, they are trying to keep it close, but you have not optically corrected. So it will not be giving appropriate near acuity. And that information, if you feed for calculating magnification for near, it will not be correct. So we usually suggest that test distance should be guided based on the addition, consider the amplitude of accommodation, plus third component that people should consider is if they have uncorrected refractive error or undercorrected refractive error. So some people who are myope or who are undercorrected also, probably they can manage at shorter distance as well. So but people should be mindful that where their optical system can focus at. Like for distance acuity, when we write 20 by 200, we know that 20 is the numerator is telling us the distance. Here and in the near vision, when people write N6, they don't bother at times to write the test distance. So N6 at 10 centimeters is not same as N6 at 40 centimeters. That we should be careful. And that is where the working distance plays an important role. And when we are calculating the magnification, we should also keep in mind the minimum acuity reserve requirement. So for fluent reading, it is simple to remember that at least 3 lines under reserve, or the ratio should be of threshold print size and critical print size should be 2:1. So that means if person wants to read N8 print in the newspaper, we should target for N4. So automatically 3 lines will be under reserve. Or if person wants to read N16 print in the devotional book, we should target N8. So you can see this is the formula that we use for calculating magnification. Best corrected near vision by target near vision into 100 by working distance in centimeter. So if you have recorded best corrected near vision, say for the first row in the example, N20 at 25 centimeter, and person wants to read N8 print in the newspaper. So rather than keeping N8, we have kept N4 as a target. And if we'll calculate, if we'll feed this information, we'll get 20 diopter as the EVP. So 20 diopter spectacle magnifier or 20 diopter stand magnifier or 20 diopter hand magnifier can be the starting device for the trial. And that way it will save your time. This is usually overlooked, and the previous presenters have already highlighted the importance of it. The myth is that because of the underlying pathology, if person is having macular degeneration or RP, whatever you do, it will not improve. And at times, if it is high refractive error, often people write no glow, dull glow, and they leave it. So we have seen in our clinic, when we did retrospective study, we looked at about 26 to 30% of the patients had significant improvement in the acuity with the refractive correction. Even at the tertiary level hospital, at times in the busy clinic, people do not pay attention to this aspect. And there are reports from the developed country also, where they have published that about 11% of the cases in their low vision clinic had significant improvement. Significant improvement means at least 2 lines improvement in logMAR chart. And what can be done? People should learn something called radical retinoscopy, the same retinoscopy, but you're doing at shorter distance to visualize the reflex if you're having difficulty. The other thing people can think about the over refraction. And if they have difficulty in finding any starting point here, they can also look at the axial length or the topography that can give you some starting point. Because often if person is having, say, very long axial length, 30 millimeter of the axial length. So you know if 23 is the normal, so how much that would correspond. So each millimeter about 2.7 diopter refractive error. So people can calculate that, okay, this person may probably have 30 diopter or 27 diopter of myopia. So let's keep that and then let's start the subjective acceptance. Similarly, topography can give about the high corneal astigmatism or so. Non-standard test distance can be used for subjective test. as we do it for the visual acuity assessment, because if you're recording acuity at 1 meter, so subjective also should be done at the same distance to quantify how much is the improvement, because if the improvement is lesser than 20/200, you may not be able to quantify and refine it if you're using the standard test distance. So we usually use non-standard test distance if person's acuity is very low, so say 20/1600, 20/2000, like that. So then we use a non-standard test distance. The other important component here is the determining the just noticeable difference. This just noticeable difference is the minimum dioptric difference that a person can appreciate. And this is applied in bracketing technique. So I hope you all understand what bracket means. There'll be one lower limit, one upper limit. And in the subjective refraction, people are often given two choices to decide which lens is better. So that lower limit, so if you look at with the example, if somebody's acuity is 6/60 and we don't have a starting point of which lens, whether person is hypermetropic or myopic, person did refraction, didn't find any glow. So what he can look at is that, okay, how much is the noticeable difference here? So to calculate that, denominator can be divided by 30 if you have recorded it in metric format. So it will give you 2 diopter as the just noticeable difference. So we can choose a bracket size of 2 diopter, which means our trial lenses should be +1 and -1, which will create a difference of 2 diopter. And we can ask person which is better, and then we can proceed further as person's acuity improves. And the other example, if you say here and here, and we can look at in the feet, if somebody is recorded in feet method, take the denominator, divide by 100, you'll get the values. So if somebody's acuity is 20/1200, you get the noticeable difference of 12 diopter. So here in your bracket lenses for comparison will be +6 and -6. So half of that you'll keep. So when you keep +6 and -6 and ask lens 1 is better or lens 2, based on the person's response, you will know whether person is hypermetropic or myopic or which side or which direction you should move further. And as acuity improves, so say for example, with -6, person's acuity improves to 20/600. So keep -6 in place. And now your new bracket is 6 diopter. So you have to keep +3 and -3 over that. And then you can carry on till person says both are similar, almost equally blur or equally clear. Then the midpoint is your endpoint of bracketing technique. And that is how subjectively we can refine and we can get the acuities. Something similar we applied here in this case when patient was referred to us and it was written CF. So herein we applied radical retinoscopy, we got her axillin done, we did refraction at shorter distance, and we got about -45 was our objective value. And with that, she was improving to 20/200. So we referred her back to the same ophthalmologist who had referred to the low vision clinic, saying that she doesn't want to use contact lenses. She doesn't want to try contact lenses, and glasses are not possible in our clinic to make it. So do you want to consider something? So they planned for clear lens extraction. And this is what she had post-operatively acuity after, I think 6 weeks post-operatively. This is what the acuities were recorded in the record. So you see this person, if the optometrist in the clinic would have noted it and would have shown that this is what the possibility is, then plan would have been different than referral to low vision clinic. Similarly here, and if you think of this specific case, people can think of topography, can think of looking at the different methods to do subjectively assessment of using astigmatic fan or stereopic set for refining and seeing how much acuity improvement can be brought, even if in the refraction people have got dull glow or no glow. Once we have refined, once we have got the best corrected acuity for distance with the correction, magnification can be calculated using this formula. So we use denominator of best corrected visual acuity by denominator of the target visual acuity. And for most of the purposes, 20/40 is considered target visual acuity, and that should be suffice. So take for example, if somebody is having 6/60 or 20/200, so therein if you keep target of 20/40 or 6/12, 5 times magnification would be suffice for them to manage board work. So That gives us a starting point of telescope trial for distance. As we discussed, it's an important component. Another important visual function, contrast sensitivity. And it helps us to understand if people are having very good high contrast acuity and still they're not happy with the vision, what could be the problem? So people may require additional illumination, or if their better eye has got impaired contrast sensitivity, if the dominant eye has got, then at times occlusion of that eye may help them read better. So those management related issues we can plan based on the assessment on contrast sensitivity. And certain environmental modification can also be suggested if we have measured this and we document, and if we find that, okay, this condition leads to impaired contrast sensitivity. So in clinic, routinely, people use Pellier-Robson chart. Some people, if they think that is expensive, can consider getting low contrast charts. These low contrast acuity charts are inexpensive, less expensive, and these are available in different contrast levels, 10%, 5%, 2.5% or so. And people can compare the high contrast visual acuity with low contrast visual acuity to see how much is the drop. And then based on that, person can be counseled and guided that, okay, that what modifications they have to make in the environment so that they can function better. The other important thing in the assessment is about the glare testing. So people can use brightness acuity tester, BAT, for objectively assessing how much is the acuity drop in the glare situation. But we know certain conditions, say albinism, rod monochromatism, cone dystrophy, patient with Stevens-Johnson syndrome, xeroderma pigmentosa would have significant glare issues. You can observe that. So therein, what we usually do is we select the appropriate filters, tinted lenses, and we take them outdoors and see how the symptoms are relieved. If they are squeezing lids, if they're bending their head, can they keep their head straight? Can they, in place of using their hand as a visor, can they use a peak cap or something else so that they're more comfortable and they can walk around? So you see that how things improve there. So that is what we do in the glare testing assessment. So now, if you look at towards the end of examination, people often think that there's so much comprehensive assessment. Obviously, how does it happen? So we use a structured format so that people can follow it and people understand what are the important component in the assessment. A structured format helps people to record things from the previous reports, their observation, different visual functions, and then plan the management. If there are any questions, I can take it here, and then I'll move on to the assistive devices.
Thank you very much for your first part, Dr. So it was a visual acuity assessment in an altogether new format, which I think definitely for low vision patients, this requires a lot of time and patience from our side to actually do it. So again, my question to you would be like, what are your indications? Like you study these patients with reasonably good visions in the Snellen's chart may also be suffering from a lot of other problems. So, and many patients may not actually know that they have that problem. They will come to us with some vague symptomatology, and we will say, okay, this is dry eye, let us treat with tear substitutes. What are your indications?
The magnification was very impressive, Deepak. It was very nice. How to calculate the magnification easily, and I think that gives us a lot of input.
Thank you so much, sir. The way we go by selection that when to do it is that when we look at the person's symptoms, at times the symptoms itself will guide you that person may have impaired contrast. Those are the indicators. The second is certain conditions, so say optic atrophy. We know that herein person may have impacted, or patient after a refractive surgery. So therein, if their contrast may be impacted. So based on that, in the computerized testing, that if you have those charts like Complog, which we have, the low contrast visual acuity comes inbuilt. At times people are not aware of. So if people look at that, yet that module is there, and if they put it in their protocol of examination, that these are the conditions where we want to measure this as well. And if you find impaired contrast, yes, we can guide the person that what modifications, what suggestions needs to be done. The other thing which often people miss is that they do not ask history of falls and other things in routine clinic, where is usually missed. So people having impaired contrast, they would have difficulty while descending on staircase at times. Because of the aesthetic sense, people will keep the similar color, similar tiles, and while descending, people will have difficulty in identifying the first or usually the last step where they'll fall. So those are the things probably the suggestions can be made.
I have one question. Gopal.
Go ahead, Srini.
Yeah,
Go ahead.
Dr. Deepak, do you have any suggestion on how to do school screening? To pick up kids, we just check the, do it with the visual acuity chart. Do you have any suggestion as to do some special tests on kids with low academic performance and things like that, so that we can pick up kids with these problems?
As of now, I think in the routine screening, people use the acuity charts, even not the Ishihara for color vision screening. That is something which we are recommending. And for contrast sensitivity, what we are right now in the planning stage, we are going to get the normative data and looking at that how the, even if people do not have any symptoms, do they have impaired contrast sensitivity or so? So those school-going children, what is their contrast levels? And at what levels do they start reporting difficulties? So once we have that data, so then we'll have the evidence to make recommendations to include contrast sensitivity as the important component of school screening. The other thing that probably our research would bring policy recommendation would be that visual impairment that has been we use for classification and for support services and making arrangement for benefits. We use only high contrast visual acuity for distance, and the other component is visual field. We don't consider the contrast sensitivity, wherein people in some cases may not fit into the these definitions despite having many multiple challenges, and they may need assistive devices and recommendations and help. So we are trying to collect the evidence through our study, and then probably we'll be able to in a better position to suggest.
Thank you.
We observed anything like what your observation is, and we thought of conducting a study.
No. See. Would you be concentrating on kids with low academic performance? Like, I mean, it might be difficult to do the entire gamut of tests on all the kids. To make things easier, would it be okay to concentrate on kids with lower academic performance, or based on the feedback from the teachers?
What we are planning to do is we'll have a normative data wherein across the different age group, starting from 5 to 15 years, kids with the normal visual acuities, whether they are using refractive correction or no refractive correction. The other group would be children having low vision in different age group and different severity of impairment. So that we would be looking at, and the point what you have raised is an important point. We'll keep into mind that their academic performance also will collect as a data, and we'll look at that if it has any bearing there.
Thank you, Deepak.
Thank you. This one. Some of the students who has refractive or corrected with spectacles comes to my clinic and say that they are not able to read from the blackboard. So usually what I find is that the blackboard is usually at the entrance. That is where the door is. And when the sunlight falls on the blackboard, the contrast is gone.
Yes.
And some of the blackboards are not black at all. and when they write with the white chalk, they can't see anything. I think the environment in which these particular students are sitting and then studying or reading is probably more important also. Like, this is also maybe considered when
Yes.
we are discussing these problems.
Yeah, so recently what we did was, as part of the continuing rehabilitation education program, we invited teachers who are involved as a special educator in Sarv Shiksha Abhiyan, SSA. So they're in those teachers we involved, and we talked about these issues that our recommendations are and what our observations are from the clinic. So they have got that messages. Yes, it's at the policy level that who has to do the assessment of the contrast lighting in the classroom, and from where the budgeting and all those things. So at policy level, yes, those things have to be considered. So when we talk about integration of low vision rehabilitation into the healthcare system, somewhere the education system also should be integrated, and then they should work together with the team of health professionals so that the kids get the benefit of the recommendations.
Thank you.
Thank you. So we'll move forward to the next presentation. Next,
Okay. Okay, then you can move to the next presentation.
Yeah. So before I move to the main presentation, I would like people, if they can identify the activities that a person with vision impairment cannot do. So there are some activities listed here. So people can put it in the chat box what they think a person with visual impairment cannot do. And some of the activities I've listed: threading a needle, reading small print in maps, using computer, playing cricket, playing tennis, playing chess, preparing meal, identifying currency, coloring, painting, online shopping, using smartphone, writing exam on their own. So people can put it in the chat box what they think would be probably difficult for them to do. And we'll see how assistive devices help them do all these things. They can do all these things irrespective of that. So when we talk about assistive technology, it's an umbrella term covering the systems and services related to delivery of assistive products and services. It's not only to help them do things, but also to improve an individual's functioning and independence, thereby improving their well-being and promoting their well-being. So this is how the ISO, International Organization for Standardization, says that it can be suggested for improving the participation. This can be useful for any device that can be used for protection, supporting, training purpose, measuring, or substituting for body functions, structures, and activities. So say when we talk about sensory substitution, so one of the important component comes in our mind is Braille. So when you cannot see and read, yes, so sensory substitution, using in place of vision, you use your touch. So that is also a part of assistive device use of Braille to prevent impairment, activity limitations, or participation restriction. And people have classified in multiple ways. The basis can be different. If your device, you can classify based on the application. So you can say devices for reading, devices for orientation mobility, devices for personal care, devices for cooking, for home management, device, and people can device based on the what components are used, whether optical devices, non-optical devices, or electronic devices, or user-based devices for low vision, devices for people with additional disability, deaf, blind, multiple disability. So people can classify based on the user, based on the components. So what we will look at is that for simplicity, that what are the different broad areas of devices and where are they used. So for distance and intermediate tasks, when we talk for patients with low vision, and our focus is low vision because if you look at the total volume or the magnitude of visual impairment, when we say in that broad spectrum, blindness means NPL bilateral, no perception of light, bilateral is very small proportion. Most of the people have some useful vision, so why not make use of it? And if a child like this girl you're seeing having albinism is using telescope and can manage studying in the mainstream school, why she should be attending a special school? And at times these kids have difficulty getting admission in mainstream school, considering that they cannot see on the board, so they should be in special school for the blind. And often people think use of devices may harm. So usually I give example of myself. I tell all my clients, all my patients, saying that, see, I have normal vision, but still I use magnifier. And such a big magnifier that you can't hide also. I use slit lamp. So that gives so much of magnification. I use light. So I use light, I use magnifier despite having normal vision, because my task requires me to see those details, which I cannot do it without using magnifier. So similarly, for simple tasks, if you're having, your vision is not suffice, you have to use it. There's nothing to hide. There's nothing to feel shy about using it. Similarly, you can see there are these days so many applications which are there in the system, but some people find it difficult to use it for some application. For some programs, they can use a telemicroscope. Like people use some binocular loops for operating. Yes, so this person is using it for computer work. So these kids can use it, binoculars or monoculars, handheld or spectacle mounted. These days we have autofocus telescopes also available from Ocutech. So people can be explained about those options that can help them work at different distances. And some of these Galilean type telescopes look very handy, looks like a spectacle, but yes, there are to get magnification. Yes, it cannot be single lens system, it will be combination. It will have little weight, but people can get used to. So we provide training once we identify that patients are finding it useful for different purposes. And many kids may use it not only for study purpose, they may also use it for the hobbies and other things. At times they may use it outdoors for sightseeing purpose. The only restriction that you have here is there's no light collecting properties. These usually gives you very narrow field of view. When we talk about 4 times magnification, you get about 12.5 degree field, and 6 times magnification telescope will give you about 9.6 degree visual field. So they'll need to scan, track. So unless they are trained adequately, just prescription of devices do not help. So often we recommend them that at least 3 to 4 sessions of training is must before you collect the devices from the optical store. So after the prescription, we provide in-house training in the simulated classroom setting, and then we recommend them to use it. And for near, if you look at the range of magnifiers that can be provided, these are all convex lenses. These convex lenses can be mounted in the form of spectacle, and the working distance will be dependent on the power of the lens. So say this kid is using a +16 diopter spectacle magnifier. So his working distance will be 100 by 16. So about 6 centimeter distance. So about 6 centimeter distance to maintain, he may have posture related issues. So we recommend them to use a reading stand to keep their book. Often spectacle magnifiers are considered good. People psychologically feel acceptable. Binocularity is possible at lower level. You can think of giving basin prism. If you're giving up to say 8 or 10 diopter of spectral magnifier, beyond 8 diopter or 10 diopter of spectral magnifier, basin prism will not be feasible to maintain the binocularity. We have to also look at the for prolonged use, and if somebody is using it hands-free system, then spectacle magnifiers are good. So those people who have tremors and having issues with the handling, therein spectacle magnifiers are a useful tool. The only disadvantage that we see here is the shorter working distance, and when they bend so much close to the reading material, if they find that the lighting is not adequate, you may need to suggest an overhead reading lamp along with it. And range of magnification would depend on how much power your local optician can provide you. We locally get up to 32 diopter of lens. From a special vendor, we have got it, 28 and 32 diopter lenses, but in international market, you can go as high as 40 diopter also in spectacle magnifier. But we have to be mindful when we give 40 diopter lens, the working distance will be only 2.5 centimeter. The other set of tools, again, convex lenses mounted with the handle. Here, and you can have it with the illumination or without illumination, with a folding handle. So people call it pocket magnifier or folding magnifier, illuminated hand magnifier or non-illuminated hand magnifier. All these are good for spot reading. So somebody has to read just bills, price tag, or limited reading. It should be fine. These are easily available in stationery shops, bookstores, and some scientific stores, but those are usually low powered. You can get up to 10, 12 diopter. You will not get as high as 40 diopter hand magnifier. So for that, you have to consult a low vision specialist. They'll have usually in their inventory for demonstration and for dispensing. And here and again, a little bit of training in how do people maintain the distance from magnifier to reading material and magnifier to eye, and how that will have relationship and implication on the field of view. So closer they keep the lens to the eye, they get greater field of view. So those things we train them in the training, that how should they position it so that they get a best advantage. Again, those people having trimmers and other things, and looking for higher powers magnifiers wherein spectacle magnifier cannot provide. And with illumination, you can have a stand magnifiers. With illumination, you can go as high as 52 diopter. Illuminated stand magnifiers are there, and the non-illuminated one, you can get up to 72 diopter lens. But as you may have seen in the clinic, your own 20D lens or 78D lens, when you use it, you look at the diameter of those lenses. So as you go towards higher power 90D lens or 78D lens, the diameter becomes small. So field of view will also, with those high powered stand magnifiers, would be smaller. So the moment it is more than 6 times magnification requirement, we usually suggest them to go for electronic magnifier, which will give them binocularity, longer working distance. But for spot reading and for the economic consideration also, if at times people prefer using these stand magnifiers because these are inexpensive, and for young kids, yes, they can easily adapt. As I said, that posture related issues, so for that, this kind of wooden or plastic reading stand can be recommended to maintain posture. And in higher powers, yes, you have a range of video magnifiers. So these electronic magnifiers can come in multiple forms. So one which on the left side you are seeing is a CCTV mouse model. So under the mouse is a camera which is connected to a regular TV. So you get magnification based on the digital zoom and the optical zoom which is derived in the system, and again based on the screen size that you are using. So most of these systems gives about 220 times to 40 times magnification, which is inbuilt in the system. If somebody is looking at higher than 40 times magnification, then they can use a combination approach. They can think of using a larger screen. In place of 20-inch screen, you can have 40-inch screen, or you can sit close to the monitor so that you achieve the relative distance magnification. So we teach those concepts to patient, that if this is the screen size you are using, you have to sit probably at this distance to get the equivalent at your home, because what we are demonstrating in the clinic may not translate if patient connects it to a different size monitor. The other thing which is advantage here is that higher level of magnification also you see binocularity is possible. Whereas in the spectacle magnifier or stand magnifier, the moment you go beyond 3 times magnification, binocularity is not possible, and shorter working distance is there. Herein people can maintain as long as 50, 40 centimeter. So normal posture, so posture related issues will not be there. People who are having optic atrophy, RP, wherein impaired contrast is there, advanced field loss are there, people struggle. Herein with the negative mode contrast, they can easily read with the good contrast, and they can cut down on the glare also because the contrast brightness can be adjusted on these electronic platforms. Thinking about the portability, if you see on the right side, this image, a young person with Stargardt's disease, for pursuing his master's, he is using this kind of magnifier, which because of the smaller screen, you can get up to 10 times magnification. So, but still useful for him to manage reading question paper in the exam, reading textbooks, anything which is available in the print. But when people have to draw diagrams, so say engineers, they can think of getting a multitasking video magnifier, what you're seeing on the right side, I'm demonstrating to a patient who wanted to draw a diagram. He said that in mathematics, at times, taking measurement, drawing, all those things become difficult with the spectacle magnifier. Going this close, I can't read it properly, and at times I'm concerned because the lighting will not be sufficient. So we demonstrated this electronic magnifier wherein the camera is located here, and it's a complete system. So because the camera is located about 40 centimeters from the desk, so you can easily place anything, and if they have to fix a circuit and other things. So engineering student can use it for that purpose. This camera can be rotated 360 degree, so person can focus at distance to view on the board, can focus it towards themselves for self-viewing, for applying makeup and other things, and for reading and writing also it's possible. This is the old CRT monitor CCTV, which with XY platform, Aladdin Classic. Nowadays, these are not available in the market. So nowadays, what people are going for are their standalone or separate cameras that can be connected to laptop, which offer the similar features or advanced features with more portability. This is another multitasking video magnifier. So as you can see, one of my colleagues is writing on the board, and students sitting this side can change the level of magnification, contrast, and make a note in the classroom. In addition to performing the rest of the functions like other multitasking video magnifier, this has OCR, which stands for optical character recognition. So it converts text to speech, not the handwritten print, but anything printed in the newspaper or books can be converted into speech. Because often in patients with low vision, what is not looked at is the fatigue. Often people work on that, okay, this much magnification works, I gave magnifier, now you read. But they come back and say that, no, I can't read for very long. So it could be because of the ocular fatigue with those applications. So when they're tired of reading with those magnification devices, with the digital screen and other things, they can put on the OCR-based system, which will convert text to speech, so they can use a combination. So they can hear those lessons and prepare for the exam. So lengthy text can be heard by them. And these days, what people are demanding for is head-mounted video magnifier. People want something like virtual reality. Can something be there, which I can wear like a regular glasses and go? But still, like a regular glasses, it doesn't come. You can see one of my colleagues is trying a head-mounted video magnifier. This is Jordi. This is there in the market for last about 10 years. They have tried to improvise some of these functions. And something similar is eSight. eSight looks a little less bulkier than this. And Oxsight is again on similar thought process. So wherein there's in the center, you see there's a camera, and then digital displays are before the patient's eye. So patient is given a battery pack, which is usually connected with the either wire or wireless technology. So you have a battery pack, you have a computer control where you change the contrast, brightness adjustment, and then you can explore those things. And if you're looking at for people with a severe visual impairment, they can also think of using OrCam. Recently, it's not a recent thing, 2005 or 2007 it was launched. So it is there since then in the market, and 2015 it was launched, so about 5 years in the market. And recently last year they have come up in Indian market also, and but it is priced about 3.7 lakhs. So considering the cost and utility, at times patient think of the alternatives which are not head mounted system. Similarly, eSight and other head mounted system, most of these cost almost similar. These are inexpensive non-optical devices for people with low vision. So many people get those readily available large print books, large print telephone dials. Some people create it for themselves. They can get large print stickers and put it on the telephone dial, or they ask the photocopier to photocopy it in 150 times or 200%, and then they print and prepare their own large print books. The only challenge with the large print book is the volume. So carrying it becomes difficult. So these days, what is happening is the smart technology on the computer gives so much accessibility options. So there are inbuilt magnification in all the computer tablet and smartphones. So people are trying to use those smart technology for inbuilt magnification or voiceover functions which are there. Like many of you may be using Siri or other Google Assistant for typing your messages on replying. But those who are familiar with the Braille and want to have Braille books to read, or want to read Braille live, like you read on the computer display. They are these systems. Refreshable Braille is a display which can allow them to access the information like email and other things, and they can scroll and then can continue reading, and they can type also in this. And the computer, this can be connected, these refreshable Brailles can be connected to mobile, computer, tablet, or the laptop. And in place of regular screen, because they cannot see, they can use the refreshable Braille display. The other thing is Braille embosser, which people call it as also Braille printing machines. So this has made things very fast, because the other earlier, like somebody presenter mentioned that getting Braille books was a challenge. Now it's not a challenge, because once we have any book, if you want to convert, you can scan the book like any other scanner. It can be scanned and converted into Braille and then printed using these Braille embosser. So no more manual typing, and voluminous books can be printed and prepared quickly and provided to patients. And LV Prasad Institute has a facility wherein we print and provide to some of the special schools also on the request these books. So if you get across some clients who need these services to get audio books or to get Braille books, you can always guide them, refer them. We will take care of them. Earlier, people were getting this scanning text to speech softwares need to be purchased. Like Kurzweil was one of the commercially available software. But these days, all these technologies are coming in the smartphones itself. So people do not need to have bulky hardwares or softwares. It's all available through your various smart applications in the smartphones itself. And in smartphone, people can have this KNFB software, which is again commercially available. About $100 is the price, which makes your phone as text reading machine. Earlier, people used to use this scanning and reading appliance, which is called SARA in brief. So for scanning and converting text to speech. So you can think of that, how many options people have who are having vision problem for accessing print, which is the major problem at times people complain about. They can use magnification, they can use reading options, so they can have pre-recorded lessons available in the format of audiobooks, or they can convert it on their own using OCR-based systems, or if they're looking at OCR-based wearable device, that ORCAM provides the solution. These are again simple non-optical devices. Most of these are, people say, is common sense approach, that if with a regular HB pencil it is difficult, use 3B, 4B, 6B pencils, which is darker. If regular blue lines on the white paper is difficult for you to identify your green line, have a bold line notebook which is having black lines with a bigger spacing for people to write in big, and they can use felt tip pen. And there are various typoscopes that are available for people to put signature or for writing their checks. The other important thing for people having impaired contrast is use of lighting. So they can have incandescent bulb, or they can have CFL or LCD or LED lighting. So when they have LED lighting and all those things, usually it's good to have with the rehosted, so they can adjust the level of lighting based on their need. The challenge with the incandescent bulb is it generates heat. So at times there's a risk that if person touches their forehead with the lamp or so, they may burn their forehead. So it's important to usually suggest them to use a whole white light rather than incandescent bulb. And for glare control, usually, and for contrast enhancement, we suggest them to use filters. Patients with rod monochromatism and cone dystrophy usually prefer this red-orange filter number 570 from Neuer is very, and similarly patients with retinitis pigmentosa usually prefer 465, which gives about 81% of the light transmission yellow filter, light yellow filter. And amber orange filters are usually preferred by people having macular degenerations. And people having anterior segment pathologies usually prefer gray or amber filters. And patients with diabetic retinopathy often prefer these plum filters. So we look for that, what their preferences are, what different light transmission, different contrasts are there. And then we give a trial in the real world situation, and then we decide what will work. So it can come in the fit over style. It can be incorporated into their prescription, or as a clip-on attachment they can be given. And in some cases, people may be suggested to use a peaked cap, a simple non-optical device for glare control. Still, despite having many advances in the orientation mobility devices, this white cane is very popular and people prefer using it. People can have for day-to-day functioning talking watch, talking calculator, talking thermometer, or they can have Braille watches, and all those things also these days are available. Braille smart watches also now available in the market. And people having diabetic retinopathy, if at times they have difficulty loading how much insulin and other things. So preset insulin syringes are available, or those with the audio clue also are available. So they can manage their level of insulin and other things and taking their dosage. In-house, we did a study to look at how the acceptance of tablet computers versus the conventional devices, use of telescope and magnifiers. And what we observed was that the duration that kids preferred. So we looked at 3 months from baseline and 6 months, and we found tablet computers were more preferred by these kids as compared to the conventional devices. They preferred to spend more time using it because it was not only for study, but also playing games and other multiple things which they could do with the tablet computer. So there is a change in the trend, the way the acceptability and the assistive devices are being preferred by students and people who are tech savvy. Now they prefer using their smart devices than using these conventional devices. And there are various studies from different places showing that how these assistive devices improve the visual functioning, the clinical visual acuities and other things. But the barriers are also many. There are evidence reflecting that about half of the people discontinue using their devices for multiple reasons. At times they're concerned about they may be convinced when you explain them in the clinic. After training, they may buy also. During the follow-up, they may come and say that no, I can manage, or this person reads out to me. They still are dependent on others to manage their tasks. They don't prefer using their glasses or their magnifiers. And multiple myths associated with short working distance. Use of assistive devices may harm their eyes. Child will get addicted to it. He'll lose his capacity, or if they are having worsening of vision, they associate with it. And at times their local ophthalmologist must have told them not to use or read at this shorter distance, or not to use digital device because this will be harming their eyes. And so those are the things which we have to look at, that how do we create awareness and how do we overcome this so that these barriers can be addressed. Psychological factors, aesthetic factors are again, which have been reported in various focus group discussions with the patients and the caregivers. So at times bullying in the classroom, the child's lower self-esteem to use it, and the aesthetic of the device is a concern. Cost, I have kept it in the last because sometimes people say that it's expensive, but we have also observed that people who are in the lower middle income group at times may end up buying something which you think is very expensive for them, but they end up buying because they find the usefulness of it. They find the utility of it. They know that how it will help their kid in the regular school. And those people whom you thought they can easily afford anything may say that no, it appears expensive, so I don't want to invest on it. So there may be something else than what they are reporting to you. So whether they consider they're looking at utility or the actual cost. Towards the end, I would say that it plays an important role in improving the person's participation, but we have to also consider the other factors: parental support, support from teachers, rehabilitation professionals, peers, people in society, and those who are going to identify and refer it. Together, we can make a difference, just not assistive devices. Only 20 to 25% of the patients may need assistive devices. 80% of our management is without assistive devices, just counseling, reassuring that yes, you can use your vision and it's not going to harm you. Thank you so much. I'm happy to take questions now.
fabulous talk. Really, really amazing to see and hear all these devices and how it helps patients immensely. This is an eye-opener session, I would say. I think Dr. Sai will completely agree with me.
Thank you so much, sir.
Absolutely, absolutely. I mean, such a overview of all the available devices. Very good. I haven't seen that mouse. Is that commonly available, Deepak? That mouse,
Yes.
Magnifier.
Yes, sir. It's very common.
Earlier, it used to be a something like a box or something like that. You have to place
Yes.
a book inside that, and
Yes. So earlier, it's there available for last, I think, 20 years. But yes, earlier the one which you used to get from Enhanced Vision was costing to the end user about 30,000 rupees or so. So not many people were getting it and demonstrating it. But nowadays these are really available easily. To the end user, it costs about 6,000 rupees, and there are multiple online portal from where also people can get it. They can get it from Amazon. So people often search once they look at the photograph and other things, they take pictures, they check multiple sources, and they can get it online, and there are local vendors also who provide it. And it's in among all the electronic devices, I would say it's the least expensive, and the highest magnification.
I would like to ask one question. Like, what is the acceptance rate? Like, with low vision, the patients come to the clinic with maybe a little more expectation than what is the real situation is. So after you suggest magnifiers, spectacle magnifiers, or any such devices, how many of them say that they cannot sort of accept it? Like,
About 50%. Upfront, they would say that they would think about it and they would come back later.
Yeah.
Small proportion of people would come back to you. So people first they have to accept their problem that yes, this was an impairment. There is no treatment for it, because if there's a additional laser or something is there pending, so they would think of that. Let me go for that laser or injection. Let me observe for it. But those who have a need, that say for last 6 months they are on medical leave, they have to join, otherwise they will lose their job, they would accept it immediately. So how do we explain them? So usually I tell my patients that, see, sir, this is all temporary. The moment you say that it is permanent, yes, so we are looking for, yes, improvement possibilities. Even in patients with RP, we suggest that, see, there are people who are working on finding the treatment. Till the solution comes, how will you manage? So that is where these things are. These are all temporary. You start using it, you see how it works, and then we will see how over a period of time your requirements may change and things might change. And if treatment comes, by all means you can explore those things. But till treatment comes, how will you manage? So we say that it's all temporary. When you say it's permanent, you have to live with it. First they get shock, depression, all those things, and then acceptance becomes real challenge, because after that they don't listen whatever you're saying.
Yeah, that's right. So this counseling part comes before you introduce them to the magnifying or the other devices, or is it along with along with whenever you try devices on or exposure?
It goes usually parallel, sir. So what we do is we try to understand who is accompanying, what their understanding about the condition is, and based on, and since how long, what they have explored, have they anytime tried anything like this? Has somebody suggested them? So at times they are, these days, like people are coming who are educated, they have searched on Google, they will say that, no, I'm looking for Occutech, I'm looking for eSight. I have searched for it and I know that this is what is going to help my child. But that is very minuscule, very small proportion of people. Some people need to be informed about it, that no, these are the possible solutions probably that can help with the current technology, and these are the best solution, and these are the merits, and these are the expectations that you can have with this, and this is the follow-up that would be required.
Okay, thank you.
I wanted to ask you a question. With the current availability of smartphones, tablets, and a lot of handheld electronic devices, which can readily magnify all the print at your will, and you can probably change contrast, color, brightness, and magnification. Has the use of Braille as well as the use of these handheld devices significantly come down?
To some extent, yes. But overall, if you look at the picture, the volume that requires these services, we have hardly, we may not have touched even 10%. 90% of those who require services. So still there's a huge market there ahead for us. So I'm really not concerned about it. But yes, we understand that understanding the technology, and not everyone is tech savvy. Not everyone is using smartphone, and smartphone at times it's not permissible by some schools still. So therein, in the classroom or in the examination hall, using a dome magnifier or a simple magnifier, probably they can get easily permission to use it, as compared to if they have to carry a smartphone or something like that. So therein, both have their own place. Similarly, the population which is elderly, at times they don't prefer using technology, and the myths associated with the use of digital screen again, and the myopia control group also is usually recommending that limited use of screen time. So therein we have to strike a balance, and then these conventional devices come and play a role. So we have kids who still prefer using conventional devices when we show them an alternative of digital screen.
Hi, Dr. Gopal. Can I give a small comment on your question?
Yeah, Niranjan, go ahead.
Yeah, so I would agree with you, Dr. Gopal. Like especially in a situation where magnifiers are not available. Like in Liberia recently, we were out of stock for devices, and it was just not possible to import devices from anywhere. We explored this possibility of magnifying with the cell phones that the families already had, and it works very well. So in addition to the camera and the magnifier which is built in the phone, there are several apps that can help the child or the patient to see better. So yes, there is a lot of potential in the mobile phones that can be explored for people with visual impairment.
There was, in fact, an NGO a few years back. I saw a call from an NGO which said that don't throw away your old smartphones. Give it to some children for low vision and things like that. They were even collecting the old phones. So I think that it has definitely made a difference, and it will keep making a difference as far as low vision is concerned. The advent of smartphones. I agree with Gopal on that.
And Deepak, I had a small question for you. It's related to the question about the acceptance of devices. Do you feel that the acceptance of devices is better for near activities compared to the distance ones, like the telescopes and all?
Both the things can go hand in hand. If you look at the number of people complaining about the near, because most of our tasks are near related, near or intermediate related. So that way, if you look at the volume of devices that are being prescribed, on the number of prescriptions that go, and the number of people purchasing it and using it, mostly it will be for the near. Rarely people would have distance related tasks unless you have something related to, say, seeing on the board or so. Telescopic devices will be of minimal use. So I know some of the clinicians also using it. A couple of people who I know who are clinicians who for their post graduations. So in the ICU, if they have to see monitor from distance, so they were using Ocutech devices. Similarly, I know there are people in some occupation wherein they have to see some digital screen from distance. They can't go closer because of the temperature or high temperature or something in their factory. So there and again, they preferred using it. But that is certainly very small proportion. And study also shows that telescopic devices use, the compliance is not very great.
And Deepak, it was an excellent talk as always, very lucid, clear. For the benefit of the people, can you also tell about the ways of getting these devices? Which are the common companies, which are the common portals from where you can get this? Because there is no point in assessing when the device is not available. And recently, as you remember, we had this significant problem in Liberia, like we just could not get devices from anywhere. So I'm sure some of our colleagues may be also facing the same problem. So can you guide about the portals from where we can get them?
Sure. So in India, if you look at CBM, Bangalore, gets most of these devices, stocks them, and provides to their partner institution. I'm sure if others also approach them, they can get it through them. The second is LV Prasad Institute. We have a resource center from us also, you can get it. The third is this Hong Kong Society for the Blind. It's based in Hong Kong. You can directly import from them as well. If you're buying in bulk, say 4 or 5 different organizations together, if they want to buy in bulk, because as you get it from the local vendor, certainly the pricing will be different rather than importing it directly. So we prefer buying directly. So most of the devices we get it from Hong Kong Society for the Blind. The Noir filters we directly import from Noir company from USA. And electronic devices, we try to source it directly from those companies, so that the moment you get through the local vendors, the cost goes up. So if your cost goes up, then the pricing for the end user also will be up, and then at times the affordability becomes issue. So we try to keep the pricing lower. The other local vendor whom you can contact us, so say Lensil Optics, Baliwala and Homi in Mumbai. Lensil is based in Pune. And in Hyderabad local, we have Murlidhar Atal, that person's name, and his organization is called OMTAO. His website is omtao.in, so people can explore there also. And so these are some of the places where people can explore. And Subhashish is another optometrist in West Bengal, Calcutta. His clinic, Soham Eye Clinic. So nowadays he started importing various devices and supplying and providing it to practitioners. So people in West Bengal can explore from Soham Eye Clinic, Subhashish Chaudhary also.
Yeah, thanks for that. And recently I also found that Amazon.in also has started selling devices online. So people can get from there as well if you can't find a vendor to get those.
The challenge there, Niranjan, is that if you get it from Amazon or Flipkart, the powers that are mentioned, the magnifications that are mentioned are usually not correct. If they say 3x magnification, you would expect 12 diopter lens, but at times it may be just 4 diopter lens.
I see.
Yeah, so we got those because these are usually China-made products from Alibaba or whatever web portal. So there are people, local vendors. So similarly, like say, I didn't name those organizations from where we got some devices for the demonstration, then we had to return it back saying that we can't do business because those were substandard products and the quality was not great, optics was not great. So real very cheap stuff which they've got it from China, some magnifying lenses, but that is not standardized. It's not good quality product, and then the labeling is not as per the specification. The good quality stuff, if you're looking for, there are two for optical devices companies. One is Eschenbach based in Germany, and second is UK based Coil. So Coil and Eschenbach products are available from their website also. Locally, Eschenbach products are available from Subhashish and this Biomedics in Bangalore. Those are expensive, but the quality is really good. So these are long lasting. So if people get those telescopes or magnifiers, they can use it for 8 to 10 years. There's no problem with it. But whereas those local stuff, every 6 months or 1 year, people will have some problem and they'll need to replace frequently.
Okay, thank you.
Electronic stuff, especially, we have to look for the warranty and durability because at times when patients pay for it, we have to look for that after sale. They don't come back saying that the button is problem or button is not working, screen is not working, this is not working, or the charging finishes very quickly. So those things we get it from Enhanced Vision for electronic devices, from Eschenbach for all the illuminated magnifiers. They also have some range of electronic magnifiers. So people can look at their website, and the local dealers here is Biomedics in Bangalore and the Soham in Calcutta. And the other place in Mumbai is Ram Agrawal. His enterprise name is Karishma Enterprises. He gets from VFO, Netherlands, these products.
Okay, thank you.
Thank you so much.
Yeah, any other comments or queries? If there aren't any further comments or queries, I would like to go to this thanking ceremony. So first of all, let me thank the three academic people who made this a very, very lively eye-opener meeting, which actually would transform the practice patterns of a lot of us, especially I am dealing with diabetic retinopathy, a lot of people who have subnormal visual acuity, pre-operative as well as post-operative, but they will benefit hugely with many of these devices. So we need to explore those options. Thank you very much, Dr. Deepak, Dr. Geeta, and of course, Dr. Niranjan. I will continue to trouble you in making our programs, because the moment I include you in my program, I know that the quality goes up by several notches. Thank you very much, the three of you. Then I would like to thank our President of the Kerala Society of Ophthalmic Surgeons, Dr. Babu Krishna Kumar, who had actually inaugurated our first Super Sunday program last month. So this is our second Super Sunday program. This will be now followed by a uveitis National Symposium conducted by Amrita Institute of Medical Sciences, followed by our Noel Moniz, Dr. Noel Moniz Memorial lecture. Oration and conference on FAQs in glaucoma on the 24th of January. So that will be our next few programs upfront. I am sure that our KSOS president will further grace us in our programs. Then I would like to thank Dr. Alexander sir, who has been a spearheading personality in the Cochin Ophthalmic Club, moving in terms of philanthropy, helping blind people. He has in multiple occasions set an example how ophthalmologists can actually make a significant contribution towards permanently blind people. Thank you, Alexander sir. And then I would like to thank Srini Dr. Srini for giving us a report card of 3 years of KSOS activities in low vision care. And finally, I would like to thank my own president, Dr. Sai Kumar, and Mohan sir, and Dr. Andrews, and Dr. Thomas Arun, and all those people who have helped. And this has been a wonderful program. I'm sure that there are a lot of people who are already hearing it, both optometrists as well as ophthalmologists alike in Kerala. And I'm sure it will go a long way in changing or transforming their practices and philosophies. Thank you very much.
Thank you. Thank you.
Thank you, one and all. Have a nice Sunday.
Yeah.